Live in 3, 2, 1. Please start, ma'am. We are live.
Namaskar and a very good evening to one and all. I welcome you all for today's webinar on clinical management of non-small cell lung cancer, what's new? And with immense pleasure, I would like to invite Dr. Kapil Goyal, who is Associate Consultant Medical Oncology at Action Cancer Hospital, Delhi, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Thank you, Garima, for the warm introduction. So today we have gathered here for the small webinar over the new management paradigm in the NSCLC. As we all know that earlier till 1 decade back, the non-small cell lung cancer used to be a universally fatal disease. But now that we have seen with the recent advances, now that the targeted therapy and the immunotherapy have come up in this arena, the survival of NSCLC has improved quite a bit. And now the targeted therapy and the immunotherapy have found their way in the neoadjuvant and adjuvant settings as well. So with this brief introduction, I would like to welcome all the speakers and all the panelists to this webinar. And to begin the session, there will be 4 small talks over the management of NSCLC, which will be conducted by our esteemed speakers, followed by a small case-based panel discussion in which our panelists will be answering the question and discussing about their practices in the management. So with this small introduction, I would like to invite Dr. Rakesh Sharma for his presentation. Dr. Rakesh.
Hi, good evening.
Hello.
Thank you, Dr.
Over to you, Dr. Rakesh. Over to you, Dr. Rakesh.
Thank you, Dr. Kapil. It's always a pleasure and privilege to be a part of such discussion which involve the AIMS team as in particular. Thank you for the warm introduction. So Garima, could you share the slides or I have to share the slides?
So you can share your slides, please.
So I will be discussing about the molecular part of the lung cancer, and I will be specifically emphasizing on the diagnostic part. Treatment part will be discussed later on by my colleagues. So how to proceed with lung biopsy, principles of molecular and biomarker analysis. The topic given to me is this today. So let's proceed. So how to proceed with lung biopsy? As we have a minimal tissue in usually all of the lung biopsies, so we have to use the tissue judiciously. So first, how biopsy can be done by either CT guided or bronchoscopic guided. Whichever the way used, we have to use the tissue judiciously. So each core should be blocked separately, and first slide should be used to determine the morphology, and later on the maximum tissue should be utilized for molecular testing. So as we know, there are multiple targetable mutations which are available in lung cancer, which determine outcome and treatment also. So we have evolved in the treatment of lung cancer. Initially, we used to treat as a single entity. Later on, we were able to divide lung cancer in 2 subtypes, which include non-small cell and small cell. Later on, non-small cell was further subtyped into squamous and adenocarcinoma. And now in the era of precision oncology, we divide lung cancer by their molecular pattern. And by the molecular pattern, it has been shown in multiple trials that patients with a targetable mutation tend to do better in long-term survival as compared to patients without any targetable mutations. So this is the diagram depicting the presence of mutations in the lung cancer, particularly adenocarcinoma. And these mutation prevalence varied as according to the geography. So in our Indian subcontinent, most common mutation is EGFR, which is reported to be around 25 to 50% in various studies across AIIMS and Tata Memorial. As compared in Western world, the prevalence of EGFR mutation is around 15 to 20%. And in that strata, the most common mutation is KRAS mutation. So we'll proceed further and we'll tend to understand each mutation separately. So as I have described the EGFR mutation in Western population, the prevalence is around 17%, which is 15 to 20%. It is the most common targetable mutation, and we have multiple agents which are active against this mutation. And similarly, there are other mutations like ALK, ROS1, MET exon 14, HER2, BRAF, RET, NTRK, and so on. So as I have described earlier, we have evolved from the diagnosis of disease by site to era of precision oncology, which includes diagnosis of lung cancer by their molecular pathology and further by PDL1 and tumor mutational burden expression. So biomarker testing in lung cancer. So as per initially in 2013 guidelines, only two markers were recommended to be tested, EGFR and ALK. And in 2018, ROS, BRAF, MET, RET were also added. And now in the latest NCCN guidelines, we ERB, HER2, BRAF, MET, RET, PDL1, and other markers have been added. And we have potential agents which are active against these mutations. So first we will discuss about the EGFR mutation. Usual patient profile with these mutation is female, Asian, non-smoker. And the prevalence has, as I have already described, is around 25 to 50% in our subcontinent. And most of the mutations are in exon 19 deletion. And the second most common is exon 21 mutation. So the kit which is recommended by FDA for EGFR mutation testing is COBA's EGFR mutation test, which is FDA approved. And another screen is QAGEN, which is TheraScreen EGFR RGQ PCR kit. So it is a PCR based test. It can also be tested by NGS also. So most of the patients which we treat with anti-EGFR therapy eventually develop mutation. So there are various mechanisms for development of mutation in these cases. There is activation of another pathway, which include BRAF mutation, HER2 mutation, MET mutation, RET mutation, transformation to small cell, T790M mutation, if patient was initially treated with first and second generation EGFR inhibitor. So it has been said that if we treat initially patients with osimertinib, we can prevent the development of T790 mutation and can prevent development of resistance up to an extent. So what about the role of liquid biopsy? The ideal way to proceed is to test these mutations on the tissue. But if we don't have tissue available with us, we can test particularly T790 mutation on liquid biopsy, although it has to be confirmed ideally on tissue diagnosis. And recommended way to proceed is always tissue preferred over plasma. And first line treatment in this era is osimertinib, which may prevent the development of resistant mutation, which particular T790M, and it has better CNS penetration and better CNS PFS. Second mutation which we'll be discussing is ALK rearrangement. More than 12 different variants has been described, and this is present in around 5 to 8% of the patients with advanced adenocarcinoma. These patients are young, non-smoker females. So, and it has been shown that treatment with ALK inhibitor is superior as compared to chemotherapy, and newer ALK inhibitors like alectinib, brigatinib has better CNS penetration and better CNS PFS. So how can we identify ALK? FDA recommended tests are IHC, FISH, RT-PCR, NGS. So usually we can test ALK rearrangement by FISH or IHC. IHC, it's a cheaper test, easily available, standard, and it is FDA approved. The kit approved is D5F3, which is manufactured by Roche, and platform used is Ventana platform. So it is the most common method used to determine ALK rearrangement, and it is available almost in every center which are involved in the management of lung cancer. So it has been proven in multiple trials that ALK inhibitors are superior as compared to chemotherapy in patients with ALK mutation. And second generation and third generation ALK inhibitors are superior as compared to first generation in terms of better CNS penetration and better CNS PFS, better overall response rates. Third mutation which we will be discussing is ROS1 arrangement. It is present in around 1 to 2% of the cases, and the downstream pathway which is activated by the mutation ROS1 mutation is PIK3-AKT-mTOR pathway, and it is sensitive to crizotinib and entrectinib. And entrectinib is the first line agent which has been approved by FDA for the management of these patients. And recommended test to determine these mutation is FISH, particularly break apart FISH, and can be detected with NGS. IHC in this case is a screening test. If IHC is positive, it has to be confirmed with FISH analysis. Moving on, fourth mutation is BRAF mutation. It is present in around 1 to 3% of the patients with adenocarcinoma, and V600 position rearrangement is the most common mutation in this subtype, and FDA approved treatment is dabrafenib plus trametinib. So the preferred method to detect this mutation is PCR or NGS based test. And combination of Debra and trametinib has been shown to be superior as compared to the chemotherapy in terms of progression-free survival and overall survival. Another mutation which is nowadays we are able to detect is MET exon 14 skipping mutation. MET can be mutated by various mutation pathways like exon 14 skipping, point mutation, amplification. But the most common mechanism is exon 14 skipping mutation, and it has to be, the presence of this mutation is in general a marker of poor outcome, as it leads to the EMT pathway activation, but these patients particularly have sarcomatoid component in their adenocarcinoma. So exon 14 skipping mutation is present in around 3 to 4% of metastatic NSCLC, and presence of this mutation is a poor prognostic marker. It is common in females, elderly, non-smoker, and also patients who do not have other mutation tend to have MET exon 14 skipping mutation. And recommended treatment is capmatinib and tripotinib. Although crizotinib and cabozantinib has also been used in this substrate of the metastatic NSCLC. So how to detect MET exon 14 skipping? Since this is a RNA-based mutation, as exon 14 can be easily missed by DNA-based NGS panel, so RNA-based NGS are recommended to detect these mutations. So as I have mentioned already, that RNA sequencing is preferred over DNA-based NGS. So another pathway which I mentioned is it can be MET amplification. It is present in around 1 to 6% of the cases, and it is also sensitive to MET inhibitor. Moving on, HER2 mutation. So as compared to breast cancer, in which HER2 is amplified, in lung cancer, it is usually mutated, and it is present in 1 to 4% of the cases, particularly females and non-smoker. And because of the mutation, it is not that sensitive to trastuzumab. However, it is sensitive to trastuzumab deruxtecan, which has been shown in Destiny lung trial. Other mutations which will be RET mutation present in around 1 to 2% of the cases. Method of detection is NGS based, which is recommended. And the recommended treatment is selpercatinib, pralisetinib. And the outcome with these agents has been shown to superior as compared to chemotherapy in various phase 1 and 2 trials. Other mutations are anti-RK fusion mutation present in around 1% of the cases, and recommended treatment is larotrectinib and trectinib. So these are fusion mutations, so can be detected with NGS and FISH. Other mutations are NRG1 fusions, and these are usually detected by NGS. RAS mutation, as I have said earlier, RAS mutations are most common mutation in lung cancer, particularly in West world. However, being a most common mutation, we are able to discover a agent which is active against this mutation in 2020 and 2021, sotorasib and adagrasib. It has decades has passed, we were not able to target this mutation, and this mutation is associated with poor outcome despite we have adagrasib and sotorasib agents which are active against this mutation. And sotorasib, which has been recently approved by FDA, is particularly active against KRAS G12C mutation. So biomarkers for immunotherapy, although PDL1 is commonly used biomarker, but it is not the robust biomarker, and the work is undergoing to determine a particular biomarker which can determine the sensitivity to immunotherapy. Currently, we are using MSI testing, tumor mutational burden, and PDL1 testing. And PDL1 is tested by IHC, and immunotherapy has been approved in first line setting as well as second line setting in patients with NSCLC, either adeno squamous cell carcinoma without any targetable mutation. This is the NCCN guideline, which shows that immunotherapy agents like pembrolizumab with patients CPS1 more than 50%, we can use single agent pembrolizumab. For patients with more than 1% CPS score, we can use pembrolizumab in combination with chemotherapy. So I have said earlier that immunotherapy is approved in first line as well as second line for the management of NSCLC. Nivolumab in combination with ipilimumab has been approved as first line management in NSCLC with PDL1 score more than 1%. So as well as pembrolizumab also. And PDL1 testing can be done by IHC20C3, PARM DXSA or SP263. Both are FDA approved. So to conclude, extensive role of biomarker testing in metastatic advanced NSCLC. Ideally, NGS should be used because with NGS we can cover multiple mutation, but as per NCCN guidelines, at least 7-8 markers which are recommended and treatment is available against those mutations should be tested. But in our setting, particularly EGFR, ALK, ROS, PDL1, MET mutation, RET mutation, BRAF, these should be tested because we have treatment available against these mutations in India also. So a lot of has been done in the management of lung cancer, and I think most advancement in molecular oncology and precision oncology has been done in lung cancer only, and it has changed the management and our understanding of the disease. So we have evolved from site-based management to precision oncology, particularly in lung cancer. So I think there is a plenty of newer research which are going on, and we will be much more wiser about the disease in future. So I will be happy to take any questions.
Thank you, Dr. Rakesh, for this wonderful presentation. Are there any questions from any of the participant or the panelists? I think there are no questions. So next, I would like to invite Dr. Shalabh Arora for his talk on bevacizumab, how it has come from principle to the practice in day-to-day practice. Dr. Shalabh Arora is a consultant medical oncology in Ujala Signal Hospital, Haldwani, Uttarakhand. Over to you, Dr. Shalabh.
Thank you, Kapil. This is sort of a mini reunion, I think, of AIMS people. So I just want to confirm I'm audible and visible. And
yes, Dr. Shalabh, you are visible and you are audible.
Right. I'll just share my screen. All right. So I'll be briefly talking about the role of bevacizumab in non-small cell lung cancer. And I have been given a slide set which basically recapitulates a little bit about how the pathogenesis of lung cancer has been coming about. So I'll just briefly touch upon these points and come to the precise point as soon as possible. So as we know, as per the Globocan data, there were more than
Hello,
70,000
sir.
cases.
Sir, your slides is not visible, sir.
Oh, I'm sorry. Let me just check. Yeah, is it visible now?
Yes, sir. Just make it full screen, sir.
Okay, yeah, right. Yeah. So, so basically, we know that lung cancer, as per Globocan 2012, there were around 70,000 cases and 64,000 deaths that were attributable to lung cancer. And since then, this disease has been on the rise in our country. And the primary risk factor for lung cancer is that of smoking. And as we know, there's a direct correlation between the number of pack years and the incidence of lung cancer. So we know that there's a roughly 20-year lag period between the cigarette consumption and lung cancer, as was evident from epidemiological data, that when there was a peak of smoking that occurred in 1900s, and we saw a concomitant peak of lung cancer occurring around 20 years down the line. The other risk factors are radon, asbestos, radiation therapy, air pollution. I think we are all aware of these risk factors, so I won't go into much detail. And the initial evaluation at the bare minimum should include the cell type, the type of pathology we are dealing with, the stage of the disease, and the functional status of the patient. Since these parameters, they are very important for us to plan the therapy for every patient, and we do this on a day-to-day basis. The clinical manifestations, we are all aware of the intrathoracic as well as the paraneoplastic manifestations of lung cancer. And the diagnosis is usually made on the basis of a CT scan or a PET scan. And then we need to obtain a tissue diagnosis. And the histology is broadly divided into small cell and non-small cell. And the NSCLC is further down divided into undifferentiated squamous or adenocarcinomas as the major varieties. We are familiar with the staging of lung cancer, so I won't go into the details of this. And early NSCLC is classified up to stage 2B, whereas locally advanced NSCLC is classified as stage 2B to 3B, and stage 4, which is metastatic, which is also known as metastatic NSCLC, is managed totally different from these two previous subsets. So we see the prognosis is heavily dependent upon the stage, so as the survival also depends heavily upon the TNM staging of these patients. And the treatment approach, basically the broad principle is you could do a surgery if it's in initial stages, which could be either a lobectomy, pneumonectomy, or segmental resection. For locally advanced, you have combinations of radiotherapy and systemic therapy. And for advanced disease, you primarily depend upon the systemic therapy to achieve control. So I'll straight away move on to metastatic NSCLC, where the therapy mainly involves systemic therapy or a symptom-based palliative approach, and radiation and surgery may be incorporated in very selective cases based on the response to systemic therapy. So the factors that affect our choice of our treatment is primarily the extent of the disease, how symptomatic the patient is, what is the type of tumor we are dealing with, and also patient-specific issues, which could include the patient's age, performance status, and comorbid conditions. So broadly, when we treat non-small cell lung cancer, we look at whether the patient has driver mutation or not. Just now, like Dr. Rakesh has pointed out, and he has gone into a good detail on how to test for these biomarkers. So if the patient has a biomarker, they go down the pathway of biomarker-driven therapy. But in patients who don't have a driver mutation identified, the treatment primarily is based on platinum-based doublet plus or minus bevacizumab. And we know that cisplatin-based regimens are slightly more effective than carboplatin, though they might be a little more toxic as well. And pemetrexed-based regimens are useful in non-squamous histology. And also now we'll talk about the inclusion of bevacizumab into upfront treatment of advanced NSCLC. So if you have a driver mutation present, if there's an EGFR mutation, you primarily treat them with EGFR TKIs. So also for ALK, ROS1, BRAF, Dr. Rakesh has already touched upon these points. And for these driver mutation positive patients, subsequent treatment, again, you fall back on the chemotherapy protocols, because these tumors are not very sensitive to immunotherapy or other approaches as well. So for patients who progress after treatment with a targeted agent, systemic chemotherapy is again the point where you have to head towards if they progress after a targeted therapy. So approach to NSCLC, if you have a driver mutation like EML4 ALK fusion protein, or you have an EGFR sensitizing mutation, or then you go down the pathway of targeted therapy. If you have patients with non-squamous histology, and here the treatment decision point takes into consideration whether patients are bevacizumab eligible or ineligible, and if they are eligible, they should be offered bevacizumab-based therapy. We'll go into the details, the evidence that backs this recommendation. For patients who are elderly or have poor performance status, if they don't have a driver mutation, then mostly they are resorted to best supportive care, since the outcome in these patients is quite dismal. And driver mutation present patients, they can still be offered targeted therapy since they are relatively less toxic. Right. So far, as we know, chemotherapy, like over the past few decades, since 1970s, the best supportive care in lung cancer, our survival was at 2 to 5 months. Then entered single agent platinum, and then with platinum-based doublets. So gradually, you can see the survival has been increasing by 2 to 3 months in every decade. And the best that we hit in 2000s was with the combination of pemetrexed and cisplatin, where we got a median overall survival of around 11 months. So I want you to keep this ballpark figure in your mind, since we'll go down and discuss how bevacizumab can further add on to this very limited 11 months of median overall survival. So we'll discuss the role of bevacizumab in NSCLC. We'll look at phase 3 trials, 2 phase 3 trials, and then we'll look at the efficacy findings that were substantiated in post-marketing studies. So there was phase 4 studies that further confirmed the efficacy of bevacizumab in this subset of patients. So the first trial was this E4599, which was published in NEJM in 2006. Here, patients with non-squamous NSCLC advanced disease were randomized to combination of paclitaxel carboplatin plus bevacizumab, or paclitaxel carboplatin alone. And those on the bevacizumab arm, after 6 months, they went on to receive maintenance bevacizumab until progressive disease or unacceptable toxicity. Here you can see the primary endpoint of this trial was overall survival, which was significantly better with the bevacizumab. And you can see that we talked about median OS of 11 months that was achieved with chemotherapy alone. And over here, we see a difference of around 2 months that is positively in favor of bevacizumab. Also, when we look specifically in the adenocarcinoma subset, since that included large cell histology as well, if you look at the adenocarcinoma subset alone, you see the survival, the magnitude of difference was even higher. And over here, the median OS was increased from 10.3 months to 14.2 months, which is a very clinically meaningful difference in the overall survival. And after OS, this trial also showed that there was PFS benefit, which was a secondary endpoint. And the PFS was also significantly improved by close to 2 months in the patients who received bevacizumab. As also the overall response rate, this was another secondary endpoint, was more than doubled with the addition of bevacizumab. The other trial, a phase 3 trial that looked at the role of bevacizumab, was the AVAIL study, which used platinum and gemcitabine. and patients were randomized to 2 different doses of bevacizumab, 7.5 and 15 milligrams per kg. And those on the BEV arm again went on to receive BEV until progression. So here the data were looked at separately and also later down in aggregate. So if you see patients who received the PFS, there was a PFS benefit with bevacizumab, relatively lower dose of 7.5 mg per kg, which was statistically significant with a hazard ratio of 0.75. And with the little higher dose of bevacizumab, also there was a statistically significant difference in PFS, which was the primary endpoint of the AVAIL trial. Then there was this SAIL, which was a phase 4 study, which looked at substantiating the results that were achieved in the phase 3 trials. So here, this was conducted over 40 countries, and patients who were treated with bevacizumab plus standard chemotherapy, they were followed up to assess their overall survival. And if you look at the data from SAIL, so this is real life data, real world setting. So over here, the median survival was 14.6 months. Again, you see 14.6 months. This is much closer to what we saw in phase 3 trials. And if you look at specifically the subset of patients who responded to bevacizumab and could continue continue bevacizumab as maintenance, in this subset, the median overall survival was even longer, it was more than 1.5 years. So if you look at these studies in aggregate, we saw that all of them, as compared to that figure of 11 months that was achieved with platinum and pemetrexed, each of these studies have shown consistently a benefit of overall survival, median survival of around 13 to 14 months, which is superior to that achieved with PEM and platinum. Again, these both phase 3 trials that we just saw, the AVAIL trial had PFS as its primary endpoint. It was a positive study. So also was E4599, which was also a positive study with primary endpoint of overall survival in favor of bevacizumab. Now we look at the other question that if patients also receive pemetrexed maintenance in addition to bevacizumab. So this question was looked at by the AVA-PEARL study, in which patients received first-line induction with platinum, pemetrexed, and bevacizumab, this triad combination. And patients who did not have progressive disease at the end were randomized to maintenance with bevacizumab alone or Bev plus pemetrexed. So here you see the PFS, which was the primary endpoint of this study, was in favor of further addition of pemetrexed maintenance with the bevacizumab. The median PFS was 6.6 months with Bev alone versus 10.2 months with the combination of Bev plus pemetrexed. And I'll go back. That was, mind you, this is from the time of induction. That is when the patients got onto the trial. They first received their 6 cycles of chemotherapy, and then they were randomized to each of the maintenance. If you look at the PFS from randomization, here again, if you add pemetrexed to bevacizumab, there is nearly a doubling of the there's a doubling of the progression-free survival from 3.7 months to 7.4 months. And if you look at the overall survival from the point of induction, here the overall survival that was achieved was 15.7 months, again unheard of in the pre-bevacizumab era. And if you look at the adverse events, since that would be a concern that you're giving patients bevacizumab and pemetrexed for prolonged period of time. So if you look at the adverse events over here, you see that most of the adverse events were actually enhanced in the arm that used pemetrexed in addition to bevacizumab. So any grade 3 to 5 adverse events were seen in 10% of patients with the combination maintenance versus Bev maintenance. And also there was a 10% difference of non-hematological adverse events. But the take-home points from this AVA-PEARL study was that first line cis, PEM and BEV followed by continuation maintenance with the combination of these two drugs achieved a PFS benefit of very significant magnitude, 10.2 months in an unselected non-squamous NSCLC patient population. And both regimens were well tolerated, but adverse events were more frequent in the BEV-PEM arm, which is sort of expected. If you are giving two agents, you would expect the toxicity to be additive. Next, we'll look at the Point Break study, which compared two commonly used chemotherapy regimens. Here, 4 cycles were given, bevacizumab, carbo, and PEM versus bevacizumab, carbo, and Pacli. And patients on the PEM group, they continue to receive maintenance with Bev plus PEM, as against patients in the Pacli carbo group who went on to receive only bevacizumab maintenance. Here, the primary endpoint was overall survival. And in the Point Break study, if you see, there was no difference in overall survival, whether you used PEM carbo Bev or you used the Pacli carbo Bev. So the chemotherapy backbone actually won't make a difference in what you are using with bevacizumab. And if you look at the progression-free survival, there was some signal of a very clinically very minimum difference in the progression-free survival between these two arms. There was a significant difference in the toxicity profile. So patients on the PEM carbo Bev arm, they had significantly higher anemia and thrombocytopenia, whereas patients on the Pacli carbo Bev arm had little higher neutropenia, and fatigue was more common on the other arm. And there was also the requirement of RBC transfusions, platelet transfusions. All these hematological toxicities were slightly higher on the pemetrexed arm as compared to paclitaxel arm. So what do we take from this trial? That this trial compared the two most frequently used Bev-containing regimens, and both the regimens worked almost equally well. There was no significant difference in survival, and toxicity was slightly higher on the pemetrexed arm, but it was not statistically significant. So we see the findings from these trials have been incorporated into the ESMO guidelines. So ESMO guidelines recommend bevacizumab combined with Pacli-carbo regimen to be offered to non-squamous NSCLC after exclusion of contraindication to bevacizumab. And also the other bevacizumab and other platinum-based chemotherapies may be considered in patients with non-squamous NSCLC. Also in NCCN guidelines, similar guidelines have been incorporated, where adenocarcinoma and large cell NSCLC first-line therapy, bevacizumab plus chemotherapy is to be preferred if there is no contraindication to the use of bevacizumab. And also maintenance with bevacizumab is to be preferred in patients who receive Bev as part of their induction chemo. So we see this in the recommendation of NCCN guideline as well, where the first-line systemic therapies for adenocarcinoma and large cell NSCLC are Bev carbo Pacli and Bev carbo PEM. Also, you could use it with cisplatin. But these guidelines have now, as we all know, have been revised significantly, and now we have immuno-oncology agents now being incorporated into first line. So probably now pembrolizumab in addition with PEM carbo or PEM cisplatin is now the preferred choice. But still, this combination of bevacizumab remains on the NCCN guidelines as one of the category 1 recommendations. So that was overall data we saw so far. What do we see if we look at the Asian patients separately? So in the SAIL study that we just saw, if we look at the overall population had a survival of 14.6 months, but in the Asian subset, the survival was equally favorable. And also the time to progression was also comparable in the overall population, and the Asian patients looked out separately. The disease control rate was also comparable between the Asian patients and overall patients. So there is no reason why we expect that our patients are going to have different outcomes from what we saw in these trials. So that was in looking at bevacizumab in combination with chemotherapy. Now, what about EGFR targeted therapy? Can we combine bevacizumab with these targeted agents as well? To answer this question, we have we'll look at these 3-4 trials that we have. So first was the J02556 study, which was conducted in Japan, and patients were randomized with EGFR mutation were randomized to erlotinib alone versus erlotinib plus bevacizumab given every 3 weeks. And the primary endpoint was PFS. If you see the median PFS with the addition of bevacizumab to erlotinib was an astounding 16 months as compared to the 9.7 months that we see with erlotinib alone. So very significant difference if in the PFS if you add bevacizumab to first line erlotinib. And again, this study confirmed that the secondary endpoints of response rate, PFS, and OS were all significantly better with inclusion of bevacizumab. There are some more trials which confirm these findings. So there are small studies in EGFR mutated subsets. The BELIEF trial, which came out in Lancet Oncology, they again looked at erlotinib and bevacizumab. So here they looked at patients, they also analyzed the patients depending on the type of mutation that these patients had. So they included 109 patients, of which there were 72 patients were T790M negative and 1/3 were T790M positive. And if you see the T790M positive subset actually does much better with the addition of bevacizumab to erlotinib. So the red line is T790M positive. They are better than the T790M negative and also the aggregate data. So probably one could argue that these mutations are not sensitive to erlotinib, and these patients are benefiting more from the inclusion of bevacizumab. That's why they are having a more favorable outcome with the combination. They looked at subgroup analysis, and they found that overall T790M patients, they did much better as compared T790M positive patients did much better than T790M negative patients, irrespective of any other factors. Also, similarly, the hazard ratio was most significant in the T790M positive versus negative. So this is particularly one subset where now we do have a much more effective therapy available for T790M patients. But in the absence of, if some patients have a contraindication to osimertinib, this is a combination that can be highly useful for that subset of patients. So BELIEF trial that provided further evidence of benefit for the combined use of erlotinib and bevacizumab in patients who have an EGFR mutation. Then another study from Japan published in 2014, erlotinib plus or minus bevacizumab. They randomized over 150 patients to receive either erlotinib alone or bevacizumab. The primary endpoint was progression-free survival, which was again similar figures, 9.7 months versus 16 months in favor of bevacizumab combination. And on subgroup analysis, almost all the groups were benefiting from bevacizumab. So also in overall survival, there was a benefit with the addition of bevacizumab, although the data were not, this was a secondary endpoint, so we cannot make definite conclusions. Another study from Japan, which combined erlotinib and bevacizumab and primarily looked at the adverse effects. So as expected, patients on the bevacizumab arm, they had a much shorter time to first onset of hypertension, the first onset of proteinuria, and first onset of bleeding events. So we are all familiar with the toxicity profile of bevacizumab, and we know that these patients do develop these adverse effects, but there were no new safety signals that were observed with the combination. So I would like to summarize that the addition of bevacizumab to erlotinib also prolonged PFS in EGFR mutation positive NSCLC. and the safety data were consistent with what we know about bevacizumab. And this combination is manageable in EGFR mutation positive patients. Again, there's a phase 3 study. The ones we just saw till now were phase 2. There's another phase 3 study which has looked at the combination of erlotinib plus bevacizumab, and they randomized 228 patients with EGFR mutation, and this study showed that the median PFS was 16.9 months in the combination compared to 13 months with the erlotinib arm alone. So what we have seen is that bevacizumab and erlotinib is a viable combination. This has been confirmed in phase 3 data, especially for patients with T790M mutation. If they have a contraindication to the use of osimertinib, they can be given this combination. So I think I'll stop here. Thank you for your time and patient listening. If there are any questions, I'll be happy to take. Otherwise, over to you,
Thank you
Dr.
so
Kapil.
much.
Hello.
Yeah.
Hello, sir. Bharat here.
Yes, Bharat, please tell me.
That's a nice presentation. Sir, एक चीज पूछना था, bevacizumab का मतलब is there any trial that were combination with second line EGFR inhibitors? All we see was like with erlotinib. So do we have any trials that were done after the newer generation of EGFR were approved and the current?
So, to my knowledge, there are no trials in second line with after we have patients who have progressed on erlotinib in combination with bevacizumab and TKI. However, patients who progress on first line targeted therapy, in the second line, you could use bevacizumab in combination with chemo. So that recommendation still stays. You can use it in combination with chemo.
So I just want to know, like currently, if the patient initially we offer first or second generation and the patient is affordable only for bevacizumab, and in later line, if we can offer, like if he is affordable for osimertinib and other higher generation. So is it any contraindication, or you can just continue bevacizumab with just changing the TKI? Will that?
I think we'll definitely need the data to answer this question conclusively, whether we can continue. But one important exclusion criteria where or you might have an overlap with osimertinib is patients with brain metastasis. They are per se a very high risk of bleed with bevacizumab. So even without data, I don't think it's a good combination to use in patients with brain metastasis, which is a common indication for switching to osimertinib in T790M patients.
Okay. Okay, sir.
Yeah.
Hello, this is Rohit. Hi.
Yeah, Rohit. Hi. Tell me.
Are there any other questions?
Yeah, I just had a question regarding your brain mets. So would you consider bevacizumab if the patient had received radiation for the brain mets?
So some of these studies have used patients with treated brain mets. So the SAIL trial, they definitely included patients who were treated and stable for brain metastasis were allowed. So I think if they're treated and stable, I would be comfortable using bevacizumab.
Okay, sure.
Yeah, so over to Kapil, if no more questions.
Yeah. Are there any more questions to Dr. Shalab? So I think there are no more questions. Dr. Shalab, it was a wonderful presentation. Thank you so much for educating us about the bevacizumab. So next we have Dr. Anshul Gupta, who would be talking about various EGFR, anti-EGFR TKIs, which one to choose and their safety profile. Dr. Anshul Gupta is an associate consultant in the Max group of hospitals, particularly in Max Noida and Max Vaishali. Dr. Anshul Gupta, over to you.
Hi Kapil, thank you guys, and my apologies because of the untimely rains in Delhi and traffic became a nightmare. I have to do it from my car. So I hope I'm audible, or is it echoing?
Yes, sir, it's audible.
Okay, perfect.
Sir, if you are more comfortable, we can let Dr. Rohit present first and
No,
take till the
still
time
be
if you are able.
Okay, so no, I can go ahead if it's all right with you guys.
Okay, it's all right with us. You are perfectly audible. Please go ahead.
Allow me to just share my screen. Okay, so my screen is visible and moving.
Yes, Dr. Gupta, it's perfectly visible. Please go ahead.
Yes, sir.
Okay, okay. Thank you, guys. So today I'll be talking about safety of EGFR TKIs. So I'll be talking about both, which one to use in terms of efficacy and which ones to use in terms of safety. So I must commend Shalab and Rakesh both for their wonderful talks. And as rightly said, it's a mini union of sorts. So let's move on. So basically, stage 4 NSCLC, by definition, all of us know it can be either M1A, which is a contralateral lung nodule, malignant pleura, or pericardial effusions. M1B, if it is a single extrathoracic metastasis, or if it is multiple, it is M1C. Most common being brain, bones, liver, adrenals, and kidney, with adrenals being the standard prototypic site of metastasis from NSCLC. So, diagnostic workout. So if we see that biopsy, we have to establish the diagnosis, we have to establish which subtype is it, and we have to do the molecular testing. So one thing we have to realize that adequate tissue for histological subtyping is critical. And in this regard, I'd like to tell that often we come across situations where both percutaneous biopsy as well as endobronchial biopsy. In such situations, percutaneous is obviously preferred over endobronchial if safety is not such a big issue, for the sheer fact that will give us more tissue, and we will have a better chance of doing molecular mutations on the same. Okay, then all patients of the adenocarcinoma with either they are adenocarcinoma or they have adenosquamous, or even in squamous with poorly differentiated histology, or if they are young smokers, or if it is not clearly mentioned that there is no adenocarcinoma in it, then they should undergo oncogenic driver mutations. It can take sometimes, as was told by Dr. Rakesh, which are the various methods to test for these mutations. And of course, nowadays the trend is that a limited lung NGS panel is being used to figure out these mutations, and some of which anyways require NGS and gene fusions, specifically the RNA ones that Dr. Rakesh spoke about. So rebiopsy at the time of progression, of course, it helps in determining EGFR resistance. Liquid biopsy may be used. I would like to share an anecdote. Yesterday only a patient came to me from Dr. Shyam Agrawal. The patient was initially a squamous cell carcinoma. The biopsy was done from a private lab, and it was said that it is a poorly differentiated squamous cell carcinoma. However, still for some reason, the patient had undergone mutation testing initially. L cross and EGFR were negative. The patient was given paclitaxel carboplatin. Subsequently, was put on afatinib, and upon progression, a liquid biopsy was done, which revealed EGFR mutation. Okay, canonical EGFR exon deletion 19 mutation. So that reiterates the need for rebiopsies and liquid biopsies at the time of progression. Then current management of NSCLC is driven by molecular testing. So either chemotherapy is there if there is no molecule, if there is no driver mutation, plus minus PDL1 expression based use of immunotherapy, and again if there is targeted therapy if you have an obvious driver mutation, which can be either EGFR, L cross, MET, or as the long list that was told by Dr. Rakesh. So if you see traditionally this value 8 to 12 months, that has been the typical chemotherapy survival rates in terms of metastatic lung cancer, traditionally speaking. But now with all these targeted therapies, with lorlatinib, we have seen that the overall survival is close to 4 years and above. So, or more than 3 years rather. So we have moved on from the place where we started, and the journey has been quite fruitful. So this is just a pie chart, a bird's eye view of what all mutations are there. And Dr. Rakesh has previously mentioned, so I'll skip it. EGFR sensitizing mutations can be targeted by osimertinib, which is a third generation EGFR TKI, either gefitinib or lorlatinib, which is a first generation TKI, and afatinib or decomatinib, which are second generation TKIs. So then let's talk about EGFR mutations, which result in sensitivity and resistance to EGFR TKI, they tend to cluster at exon 18, 19, 20, 21. Basically, these are the four exons where of EGFR where all of these mutations are largely clustered. So I think all of us know what a deletion, insertion, and a point mutation means. And these mutations, they can either be extracellular or intracellular. Again, based upon that, the tyrosine kinase intracellular domain, they have exon 18, 19, 20, and 21 mutations. And if you look at the frequency, of course, the most common being exon 19 deletion, 46%. I'm not particularly sure which data it is, but even in India, it is most common. And exon 21, it is also L858 is 37.5, and the rest T79M is 4.1. Some of them may be primary T790M, and some of them may be secondary on progression. So EGFR positivity rate, if we compare it, has traditionally been known and seen that Asian women, population, the population with who are never smokers or who are not heavy smokers, they tend to have a larger proportion of EGFR mutations, and the geographical and racial difference is quite clear, with almost 50%, approaching 50% Asian population, have EGFR positivity, while the Western population, the Caucasians, the Afro-Americans, there it is 10 to 25% largely in non-small cell lung cancer. So for India, however, this rate still hovers around 25 to 30% in various studies. So most common found EGFR mutation in NSCLC, exon 19, as we have seen, and L858R point mutation in exon 21. For the patients with advanced NSCLC harboring exon 19 deletion or L858 mutation, EGFR TKIs are the standard first-line therapy. And even if there is high PDL1 associated with EGFR mutations, all of us need to remember that only the EGFR need to be targeted. There is no available data to either target PDL1 inhibitors upfront, PD1 inhibitors upfront, or a combination of EGFR EGFR inhibitors along with immunotherapy in such patients. And EGFR mutations other than exon 19 and exon 21 L858 are uncommon mutations, as we all know. So this is just a historical summary of from where we started from 1993, where development of EGFR targeted therapies, it started. Then the IPASS trial, in 2009, it came along, and it tested gefitinib in EGFR TKI, gefitinib showed its benefit, its efficacy. And then, along the line, Lux Lung and Aura 1, Aura 2, and of course the Flora study, which has now demonstrated the efficacy of osimertinib, and the other studies as we went along. So of course, while we are choosing for EGFR TKI directed therapy for a first line as first line in a patient with metastatic adenocarcinoma lung, so two things obviously have to be taken care of. That one is, of course, the efficacy, that what would be the PFS and the OS, and what would be the safety profile, what would be the adverse effect profile of the particular drug. So just this is a broad cross-trial comparison of the drugs that have been approved for EGFR mutated metastatic NSCLC. So this is the PFS comparison. So the Lux Lung trial, it compared afatinib versus gefitinib, and of course, afatinib being a second generation TKI has a better PFS. The curves they separate here. The Archer trial, which again it compared dacomatinib, which is again a second generation EGFR TKI versus gefitinib. So it also we can see there is a wide separation of the curves, and the hazard ratio was 0.59. However, if you see the Flora trial, so the separation of the two curves were seen almost immediately, vis-a-vis if you see in these two studies, almost 6 months and 1 year's time was there before the drug actually started to show that that extra benefit to the patient population. Although again, it's a cross trial comparison, so the caveat of that always stands. So then we come to the head-to-head studies, between second and third generation EGFR TKIs. They obviously have shown, as shown by the previous Kaplan-Meier curves, that, they have shown that second generation as well as third generation are obviously better than first generation. Let's see the magnitude of the benefit in between two. So erlotinib, if you see, versus geftinib, more or less the same. And if we see afatinib versus gefitinib, again, they are more or less the same in this in phase 2b. However, in this phase 3 Archer trial, decomatinib versus gefitinib, it is 14 months versus 9.2 months. So there is substantial benefit with a hazard ratio of 0.59, and the biggest magnitude of the difference comes in osimertinib versus the first generation TKIs with a hazard ratio of 0.46, which tells us that the chances of progression are 54%, like lesser likely when we use a third generation EGFR TKI or osimertinib vis-a-vis a first generation one, with a clearly 8-month PFS difference between the two. So obviously, PFS is a direct measure of a drug benefit. And as mentioned in the previous slide, there was an immediate separation of the PFS curves, and it has, provided with the unprecedented improvement in PFS, hazard ratio of 0.46 in metastatic populations. This is a hazard ratio which is not easily seen. Now let's come to the safety profile of that. So let's look at the first generation first. EGFR TKIs, gefitinib and erlotinib. So again, their clinical targets are the same. The recommended doses are 250 mg OD and 150 mg OD respectively. We all know that part. And the second generation TKI, afatinib, is approved in 40 mg OD. But afatinib is also known for targeting some non-canonical mutations, or so-called the rare mutations. That is, it targets definitely exon 19 deletion and L858R exon 21, but along with them, these are the other mutations that it also targets, and it has been recommended by guidelines to be used in patients who have such rare mutations. Okay. Decomatinib, again, it also targets HER2, amplification, HER4, along with these two. And decomatinib is again under regulatory review for first line by US FDA. Osimertinib, as we all know, has been approved, and it targets, apart from exon 19 deletion and L858R, T790M mutations. So this is the major difference between third generation and first plus second generation combined, that there is addition of T790M mutation which are targetable with osimertinib, which are not targetable by first and the second generation ones. So this is the structure. So all we need to see here in this one is that geftinib and erlotinib are reversible. The second generations are irreversible pan RB2 inhibitors, and the osimertinib being irreversible but selectively. So it we know that whichever drug is more selective tends to cause lesser of side effects and more of efficacy. So this is what is represented in this particular slide. So again, comparative selectivity, if we see, so with T790M, osimertinib is like with both T790M and EGFR mutated. Afatinib, both wild type and you see the selectivity patterns, it overlaps here. However, if in osimertinib, the wild type and the mutated ones, they are affected at very different concentrations, not at a similar concentration. So hence they are lesser toxic, pharmacokinetically speaking. So this is just a very colorful and a very busy slide. And so all of these drugs, if we see, they can cause potentially rash, diarrhea, nausea, vomiting, stomatitis, skin and nail changes, and elevation of liver enzymes, fatigue, and ILD related events. I'd rather skip this. This is such a busy slide. And the frequency and severity of selected clinically relevant all casualty adverse effects, it varies. So the second generation ones, they tend to have a higher frequency of adverse effects, because of pan inhibition of ERB2, such as rash and diarrhea, than the first and the third one. So although they have got some degree of activity with the non-canonical mutations, they have got better PFS perhaps as compared to the first generation ones, but it comes at the cost of higher toxicity in the form of rash and diarrhea. And EGFR TKI induced rash and diarrhea are usually mild to moderate, but their severity and frequency can vary. As again said, patients with second generation ones, they can have higher rash and diarrhea. And in case of rash of erlotinib and gefitinib, the frequency is higher with erlotinib as compared to gefitinib. The difference can be possibly because of the pharmacokinetic properties, or something else that we perhaps don't know yet. And reason for liver dysfunction is more with gefitinib rather than other EGFR TKIs. As again said previously, the reason for that particularly remains not clear. So let us look at the safety data with in Archer study and in the Flora trial. So in the Archer study, if you see, diarrhea was there, in 87% of the patients with dacomatinib. The nail changes were there in 61%. Stomatitis 44%, skin changes, dry skin again 27%. However, if you compare same in when osimertinib was given, and you see across the comparator arm, it was fairly similar, 59 versus 57, 20 versus 19, and so on and so on. So, there is, because of the selectivity of the third generation EGFR TKI osimertinib, there is not marked difference between the adverse effect profile of the two. And this is what is also mentioned in this is so grade 3-4 adverse effects. If you see, then osimertinib has only 2% as compared to afatinib and dacomatinib, which are higher up, 14% and 8% respectively. Then rash, if we see, is only 1% vis-a-vis 16% and 18% above with the dacomatinib and afatinib. And if you see other side effects, all the side effects grade 3. So it is 49%, 63%, and 34%. Again, the least amongst the second and the third generation EGFR TKIs combined. So one also has to understand this part now with the increasing PFS and overall survival. The quality of life is increasingly becoming a very important issue that we have to deal with. And I have seen in my personal experience, I can tell, and I think all of us would agree here, that, while prescribing, we would all often do this, that if a patient is there in the first line, and, if the patient can afford, then we would like to start with osimertinib, which is the third generation EGFR TKI, purely on the basis of the fact that the patient will have better efficacy and an improved adverse effect profile. And if perhaps for some reason the patient cannot afford that, and I'm sure the hosts, they will be looking into this thing, that how can we make it more and more affordable. So if for some reason, if it is not affordable for the patients, we would rather start a first generation TKI rather than second generation TKI, simply because it is far less toxic, and the magnitude of benefit, the incremental benefit which we derive by using a second generation TKI is far less, and perhaps doesn't justify the addition of these toxicities. So again, this is the same thing that we just said. So I'll skip this slide. So grade 3-4 adverse effects, with dacomatinib were reported in 63%, which is very high. It is practically close to 2/3 of the patients. And again, if you have a frequent visits, so the benefit of EGFR TKIs is that it is an oral therapy, and patient does not need to visit the medical oncologist too many times in their clinics and offices. But if the toxicities are such, it further worsens the quality of life. So I'll skip this. So, as we say, as first line treatment, second generation EGFR TKIs, they have higher frequency of adverse effects because of the pan inhibition of B2. We've seen that before. If adverse effect severity does not lessen or cannot be managed, the dose should be reduced, and the dose adjustments have been typically more with second generation EGFR TKIs. So osimertinib is considered to be well tolerated at the recommended dose of 80 mg. The dose management scheme states that 40 mg may be given under certain circumstances. But I think my experience and most of us would agree on that part, that 80 mg is a reasonably well tolerated dose for osimertinib. Okay. So then this is the dose reduction due to adverse effects. In Lux Lung, it was 52% versus 1.9%. In Archer, it was 66% versus 8%. And in Flora, it was just 4%, which was practically lesser than the comparator arm as well. So then dose reduction due to adverse effects. So it's the same thing that we discussed previously. Let's skip this. So if you see, the diarrhea and fatigue is just 2.2% and 1.4% more than grade 3, which is very reasonably and very acceptable data that we can use. So post hoc data analysis are an issue because they neither confirm the population, or they don't have the randomization, so they don't therefore have the statistical strength, or the recommendation cannot be derived them with the same degree of conviction. Dose reductions resulted in lower incidence of severity of grade 3 adverse effects. However, after dose reductions, the incidence is much higher in osimertinib and Flora. Okay. So coming to quality of life, Lux Lung 7 trial, it compared afatinib with geftinib. Both were same. Although we saw that afatinib had perhaps higher degree of adverse effects. In Archer 1050 trial, the patient's quality of life was significantly improved from the baseline in patients treated with geftinib. Okay, so despite the fact that probably decomatinib had a higher PFS and a better hazard ratio, the quality of life was worse. And in Flora trial, osimertinib showed a consistent trend towards a better improvement across the groups as compared to geftinib. However, they did not reach any statistical significance. But I think it's a matter of common sense to realize that if the patient is having lesser degree of side effects, and the patient is having a higher PFS, a higher overall survival, then the quality of life should be better. However, this was not statistically proven, but the trends were there, which were positive. So this is the same thing which we mentioned in the previous slide. So global QOL significantly worsened in the dacomatinib group versus the gefitinib group. And as we previously said, one of the important goals of treatment in a metastatic patient who has probably 2 or 3 years to live is a good quality of life, and that should not be compromised upon. Okay. So then we are talking about now EGFR TKI versus chemotherapy. So geftinib in IPAS versus paclicarbo, and NEJ002 versus again paclicarbo. So if you see, the time to clinically significant deterioration in pain and shortness of breath and daily functioning favored gefitinib over paclicarbo. In erlotinib, likewise, if you go ahead, erlotinib improved all assessments, including a symptomatic progression and time to deterioration to TOI. So quality of life, if we see afatinib, again, afatinib and geftinib have got better quality of life profile, but decomatinib, of course, has a worse quality of life profile as compared to gefitinib. And this had been shown in various quality of life studies undertaken with these questionnaires. So how do we manage adverse effects? So one thing is very much clear, that any patient who is having EGFR TKI therapy will perhaps have some degree of rash at some point in time of their treatment. And many of them, they also have diarrhea. So let's see, how do we manage the two? So this is the percentage of patients who undergo these adverse effects. We have seen that previously, but diarrhea, if we can see, is highest in afatinib group, and it is lowest in erlotinib. Along with that, geftinib and osimertinib come a close in between. So most common skin adverse effect is acneiform rash. So the grading If it is less than 10% of the BSA, it is grade 1, 10 to 30 is 2, and more than 30 with erosion, vesicles, and desquamation is grade 3. And if it is blisters, ulceration, or epidermal denudation, including BSA of more than 30, then it is considered to be grade 4 as it is shown here. So what would we do? Grade 1, we continue the TKI. We apply a topical anti-inflammatory antibiotic such as clindamycin, and that should suffice. Topical corticosteroids usually are not indicated, but may be considered if there is a great degree of itchiness and discomfort to the patient. Grade 2, we can continue the TKI at the current dose, interrupt the treatment if it is intolerable. We can give oral anti-inflammatory antibiotics for 6 weeks, such as doxy and mino, and clindamycin again topically should be applied simultaneously. We may consider the use of oral steroids for a short time. A short course of low dose steroids can be used. And grade 3, of course, we have to interrupt the treatment. We have to refer to a dermatologist, and we have to resume at a lesser dose when it comes down to less than or equal to grade 2. Again, the management is, if an infection is suspected, then something which can act on the staphylococcus, either cloaxacin and this thing. If it is MSSA, then cloaxacin and cephalexin can be used. Consider testing for bacterial skin swab for bacterial culture, KMNO4 washes, and etc. And topical steroids along with antimicrobial combination should be used. If it is a grade 4, then it needs to be managed in an intensive situation, in an inpatient situation. You have to interrupt. You may have to refer to a dermatologist, and has to be taken on an emergency level. So, what about acneiform rash with osimertinib? For any grade 3 adverse reaction, we have to withhold for up to 3 weeks. If reaction improves to grade 0 to 2, we have to resume at same dose, or we can reduce by one level, that is 40 milligrams. If the reaction does not improve within to grade 0 to 2 within 3 weeks, then we have to permanently discontinue. And this is the, I think, grading of diarrhea, which we all know. So grade 3 or more, we have to do more aggressive management, treatment and interruptions, reinitiation at a reduced dose along with IV fluids and anti-motility drugs and etc. And this thing, if it is medically complicated diarrhea, and decreased performance status with fever, sepsis, neutropenia, frank bleeding, dehydration, these are all the complications that can present with a diarrhea, which may be initially due to the EGFR TKIs, but then they can be complicated by further of all of these factors. So most cases of grade 1, grade 2 can be managed by anti-motility drugs such as loperamide or resigatrotil. So diarrhea management, if you see that antidiarrheal agent, dose reductions, and dose interruptions are the 3 modalities of treating diarrhea with TKIs. And then again, all of these can be used. All of these need to be usually used in erlotinib and afatinib. However, not much requirement is there, since the baseline diarrhea rate for osimertinib is quite less. So pharmacological management of EGFR TK induced diarrhea. Grade 1, we give 4 mg, that is 2 capsules of loperamide immediately, stat, and 1 for each loose stool, and till there are no bowel movements for 12 hours. Again, maximum of 8 capsules per day. And for grade 2, we give 2 stat followed by 2 mg after each loose stool till there are no bowel movements for 12 hours. We have to assess simultaneously for dehydration and imbalance, and clinically take a call on whether oral fluids are enough. Grade 3 and above, they require hospitalization. You have to continue anti-motility drugs, and aggressive resuscitation and fluid replacement needs to be there. So when it comes to osimertinib, for any adverse reaction, grade 3, withhold the treatment for up to 3 weeks. As previously mentioned, that if it comes down to grade 0 to 2 within 3 weeks, then we can resume it at the same or decreased dose. Or if it comes down to less than, if it doesn't improve, then we have to permanently discontinue. So to summarize the toxicity profile, second generation EGFR TKIs, afatinib and decomatinib, they have got a worsened adverse effect profile, and they lead to significant dose reductions. So as we can see, 66% in Archer versus only 3% in Flora. And grade 3 adverse effects are also higher, and they have, decomatinib specifically has a poor quality of life scores when it came to that. So third generation osimertinib, on the other hand, we know that it has a better efficacy, better tolerance, better quality of life profile. So it is favorable and it is recommended in all of the above categories. So this is NCCN guidelines. And of course, the first line category 1 recommendation is osimertinib. And if it is a EGFR mutation positive patient in first line, and then comes the role of others. So what are the takeaway points? If you see that in the FLORA trial for EGFR positive NSCLC, a statistical and clinical significant improvement without any concerns related to toxicity profile was seen there. And on the other hand, second generation EGFR TKIs, they have not very good toxicity profile and a poor quality of life. I think with that, I conclude, and I would be happy to answer a few questions if.
Thank you, Dr. Anshul, for the wonderful presentation. So are there any questions from any of the participants to Dr. Anshul? I think there are no more questions. So thank you so much, Dr. Anshul. This was a wonderful presentation. I hope we all learned a lot about the safety profile of TKI and which one to choose. Osimertinib being our favorite all the time, of course. So with this, I would like to invite Dr. Rohit Reddy to have a chat about this management of resected NSCLC. Dr. Rohit Reddy is a consultant medical oncology in Yashoda Hospital, Hyderabad. Over to you, Dr. Rohit.
Hi, Kapil, and hello, everyone. So it's always a pleasure to share this particular online dais with all of you. And 1 second, please. I'll just share my slides. So I hope now they're visible, right? I hope my slides are moving.
Yes,
and
yes, they're visible, Dr. Rohit.
Yes,
Yes, Dr. Rohit, you're
So
visible. Go ahead, please.
I think my work has been fairly easy by all of the other speakers. We went through the workup of lung cancer. Then we saw how Bev worked in lung cancer. Then later on again by Dr. Anshul sir, he explained detailedly regarding what are the different modalities of treatment which are available for EGFR mutated metastatic lung cancer. So shifting gears, I'll be just going into one particular trial. My entire discussion during the next probably 15 to 20 minutes will be based on the ADAURA trial. So I'll be describing or discussing newer paradigms in treatment of resected EGFR mutant early lung cancer. So as we all know, lung cancer is essentially the leading cause of death worldwide. And probably we also know that non-small cell lung cancer accounts for about 85% of this case. This figure, I'm not so sure. It's actually quoted probably in the Western studies, probably they find around 30% of patients with resectable disease at diagnosis. But in our day-to-day practice, I know that this percentage is quite less. I've tried to find out what exactly is the percentage. Unfortunately, I couldn't find out. Probably it should be around 15% according to my estimation. So we all know that in early stage lung cancer, of course, patients go for an initial surgery. And definitely we also know, according to the LACE meta-analysis, that adjuvant cisplatin-based chemotherapy is standard recommendation, which is given for stage 1B to 3A. The absolute degree of benefit by OS is probably the hazard risk was around 0.89. The DFS is 0.84. The absolute percentage wise, it was probably around 4.7 around. I don't remember. But despite giving standard of care treatment, almost around 50% of stage 1B and a higher percentage of stage 2 and stage 3 patients, they do relapse. So now we have to do something for these patients so that they don't relapse and so that their survival improves. So regarding this, we also know that almost, at least in Indian population, 30% of lung cancer patients are positive for EGFR mutation. So at least taking into this consideration, we might find in the future many patients of our resectable lung cancer patients being positive for EGFR mutation. And this was consistent across the stages that almost around 30 to 40% of our patients, they do test positive for EGFR mutation. And hence, based on this common fact, initially erlotinib was tried in the SELECT trial. Later on, gefitinib came. Later on, now we have the ADAURA trial where osimertinib was used. So finally, coming into this particular trial, this is the ADAURA trial, in which they have tried osimertinib as an adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive non-small cell lung cancer, and they need to have a complete tumor resection. This was initially published in NEGM probably around 2020, and later on we had 2 or 3 updates coming up. So this was this was key inclusion criteria. They have taken patients essentially from stage 1B to 3A. The patients in the inclusion criteria, they also included patients who, irrespective of their chemotherapy, adjuvant chemotherapy status, that almost around 30% of stage 1B patients received adjuvant chemotherapy. Around 80% of stage 2 and stage 3 patients, they received adjuvant chemotherapy. The performance status had to be good. It was 0 or 1, and they included only patients who had an exon 19 deletion and an L85R mutation. They did not include those rare mutations which were described previously by my other speakers. The brain imaging was mandatory here, but one caveat was that they had also included CT or MRI as a modality of choice for brain imaging. An important point was that a complete resection with negative margins had to be included. If the margins were positive, they were outright excluded. The duration which was recommended between surgery and randomization to the drug was recommended around 10 weeks if the chemotherapy was not used, and 26 weeks if adjuvant chemotherapy was used. And based on the stratification factors, they actually used the standard dosing of drug, which was 80 milligram OD, which was as described by as was in the FLORA trial. The other arm, it was again placebo. The primary endpoint was DFS, which was by investigator assessment, and this was specifically in stage 2 and stage 3A patients. And they assumed a superiority of around the assumed DFS should be of hazard risk of 0.7. The other key secondary endpoints were DFS in the overall population, the OS, and the health-related quality of life. Actually, initially it was started as an blinded study, but after 1 year, when they started noticing that the drug was quite effective, they unblinded the study and then they published the interim data. Unfortunately, my slides only contain the interim data of 2 years. I'll just orally describe whatever has happened recently regarding these updates. So these were again the key inclusion criteria. Important was that only exon 19 deletion and L858R mutation patients were taken, and they were allowed an adjuvant chemotherapy. This was one of the key criticism, that CT scan was also taken as one of the inclusion criteria. Important exclusion criteria were that patients should not receive any pre or post operative radiotherapy. They should not have undergone any neoadjuvant chemotherapy. No neoadjuvant EGFR TKS were allowed. CYP3 inhibitors less than or equal to 3 weeks prior was not allowed. And this was also one more key exclusion criteria, that patients who have had only segmentectomy or wedge resections, which are usually preferred in stage 1A patients, they were also not allowed. So these were the baseline characteristics and they were well matched. What I would like to highlight over here is the percentage of females was quite high. It was almost around 68%. This is consistent with the routine statistics that we find almost 70% of our patients, of the females they usually turn out to be EGFR positive lung cancers, and most of them are non-smokers. The trial had a higher population of Asians, probably correlating with the fact that we Asians tend to be more EGFR positive. And almost this is one key criticism regarding the trial, that 45% of the patients, they had only CT. So probably CT might have missed some, as we all know that MRI is a diagnostic modality for brain imaging. But here CT was almost performed in around 52% of the patients. So we don't know whether they had any tiny brain mets which were missed out in the CT scan. And the HSCG staging which was used was 7th edition. They had almost an equal distribution, 1/3 population of each stage. Adjuvant chemotherapy was again used in around 60% of the population. So this coming to the primary and key objective. This was the DFS, this was the primary, this was an interim analysis. And as we can see here, the median DFS was actually not reached according to this particular interim analysis. The hazard risk was almost 0.17, thereby actually making the fact that this drug is quite effective. It decreases the risk of disease recurrence by almost 83% if we take into the primary endpoint. Even in the overall population, when we take all the other stages together, the hazards were around 0.2. Even if you take the update which has come up recently, which was published probably around 1 month ago in JCO, the in the overall population, the drug reduced the risk of disease recurrence by around 73%. You can actually go through the JCO article, and it's quite effective. These were the 2-year DFS. As you can see across all the stages, this particular drug is effective. It almost reduces the risk of disease recurrence by more than 70%. Even if you go into the subgroup analysis, it's quite effective everywhere, irrespective of the sex, age, smoking status, whether it was Asians, irrespective of the stage. It was more effective in stage 2 and stage 3, and also in both the mutations which were taken. This was the overall survival update at the interim analysis, and even at the recent update which was given, the median overall survival was not reached in both the arms. One key criticism is that for a drug to be effective in adjuvant setting, overall survival is taken as the gold standard. But as we know, we might not find the median overall survival quite early. So most of the times DFS is taken as one of the surrogate marker. But irrespective of that, AstraZeneca has now reported an OS benefit also, which I think would be presented at any of the upcoming international conferences. They've also told that there was an overall survival benefit. I'm not so sure what is the magnitude. I need to look into it. Was this the first trial which actually demonstrated that EGFR TKIs are useful? No. This was the first trial which was actually a select trial. This was a phase 2 trial. They've taken around 100 patients and they've used erlotinib after adjuvant chemotherapy in resectable EGFR mutant non-small cell lung cancers. But one important point was that radiotherapy was also allowed here. And definitely this particular trial has shown that there was a good DFS benefit, but unfortunately an OS benefit was not demonstrated in this particular trial. Then this is one more important Chinese trial which was conducted. They've taken stage 2 to stage 3 lung cancer patients, EGFR mutant, and they've tried gefitinib versus adjuvant chemotherapy. Here also there was a significant DFS benefit. In fact, if you go through the NCCN guidelines, osimertinib is definitely recommended as a drug of choice in resected EGFR mutant lung cancers, but even erlotinib, gefitinib, and decomatinib are recommended as category 1 indications in case if the patient does not effort, if he's not efforting for osimertinib. So we may use this particular drug if in case we find an eligible patient who is EGFR mutant. And also as we all know, the type of recurrence has an impact on overall patient outcomes, especially post-surgery. We know that local recurrences, they can be managed with probably modalities such as SBRT or repeat surgery, but distant recurrences, they tend to kill the patient. And we all know that CNS recurrence is very important, especially in lung cancers, because CNS brain is a sanctuary site for all these resistant clones, which is not properly targeted by the first and second generation EGFR TKIs. This is where actually osimertinib stands out, that it has very good CNS penetration, and hence probably that is why we found that this drug was particularly more effective, and it has shown a greater magnitude of DFS benefit cross comparing with other EGFR TKS. So this is the type of disease recurrence. Also, what was important was that only 11% of the patients in osimertinib arm at interim analysis had a disease recurrence, which was compared to almost 46% of the patients in the placebo arm. And predominantly in osimertinib also, we found out that only 38% of the patients had a metastatic recurrence. This is very important, that the distant recurrence was also quite less in the osimertinib arm as compared to the placebo arm. What is important over here is that almost 10% of the patients in the placebo arm who had a disease recurrence had CNS as their site of recurrence, compared to only 1% in the osimertinib arm. Even if you take all other sites of recurrence, it was quite less in osimertinib arm as compared to the placebo arm. This is the absolute magnitude. Again, if you take into account this particular CNS DFS, this is also quite good with osimertinib, and the median DFS was not reached as compared to the placebo. Safety wise, it was already described by Dr. Anshul, and this is a quite safe drug. I've particularly used this particular I've used osimertinib in 3 of my patients for the past 1 year, and I can assure you that none of them have any serious side effects. Of course, they have mild diarrhea, probably skin rash, which are usually managed with routine OPD based prescription. And compared to afatinib and dacomatinib, I would definitely prefer this drug if given a choice. This is again the different side effect spectrum, and I would not go in detail because we all know that all EGFR TKs, they cause diarrhea, paronychia, skin issues, and rarely ILDs. This was again a subset trial which was published. There was a key criticism that using chemotherapy might have changed the DFS results in either of the arms. But again, it was published by the authors that irrespective of use of chemotherapy, the magnitude of benefit of DFS actually remained same. Whether you have used adjuvant chemotherapy or whether you have not used adjuvant chemotherapy, DFS benefit usually doesn't change. So this is a key actually outcome or endpoint which was described. So again, even in the stage 1B, irrespective of whether you had used an adjuvant chemotherapy or you had not used an adjuvant chemotherapy, the magnitude of benefit was quite good. Whenever we prescribe a drug in adjuvant setting, we are always worried about whether they have any impact on the health related quality of life. So this was a health survey which was conducted by using this questionnaire, which was at SF36. These were the criteria which were included. It included a physical component and a mental component, which is almost similar to other methods which are available. And finally, this is very important to know that there was no deterioration in the quality of life. This was also observed in metastatic setting as previously described, and hence proving the fact that this is a very safe drug. This is a drug which is effective in adjuvant setting, and definitely we'll have to, I think, prescribe this or give an option of this particular drug to an EGFR mutant resected lung cancer patient. Some important criticism points. I actually wanted to add some important criticism points. One was that the rare mutant EGFR positive lung cancer patients, they were not included, and almost 50% of the patients, they had only CT scan as their modality of imaging. So we don't know whether we are missing any asymptomatic brain metastasis in this particular population. The other important criticism point, which was obviously discussed, was that we don't know whether this drug actually causes any OS benefit. One particular theory is that the magnitude of benefit, which is predominantly driven, is probably by decreasing the amount of CNS events. And we all know that osimertinib is a good drug, especially for preventing or for decreasing the brain cancer metastasis, for the brain spread. The theory is that probably we are only delaying the spread of the disease to the other sites, because if you see the recent curves, they actually tend to merge once you have stopped the drug beyond 3 years. The 3 years was the duration which was specified in this particular trial. So beyond 3 years, if you actually see the curves, they started to merge with each other. So this raises the fact that whether we are actually increasing an overall survival or whether we are just delaying the spread of the disease. So to answer that question, I think they are actually conducting one more trial similar to GIST. Now they are comparing 3 years of osimertinib versus 5 years of osimertinib. And also we don't know whether this drug is effective in neoadjuvant setting, for which they are actually conducting the Neo ADAURA trial. There is also an ADAURA 2 trial which specifically focuses on the stage 1A population. Stage 1A was not included in the original ADAURA trial. And similar to durvalumab, there is also a trial using ADAURA along with chemoradiation therapy, along with concurrent chemoradiation therapy. So definitely, I think probably in the coming few years, apart from resected lung cancer patient, we might find increasing use of osimertinib even in other settings. So coming to brief summary, definitely adjuvant osimertinib has to be recommended for every resected EGFR positive lung cancer patient, as we know that it's showing a good statistical DFS benefit. The magnitude of reduction according to the recent data is almost 73%. And we've already described that this is very good drug for decreasing the brain metastasis, and hence there was a clinical improvement in CNS DFS. The safety profile is quite adequate. So this is definitely a practice-changing trial, and it's almost discussed in most of the platforms. Thank you. I hope there are no doubts.
Thank you so much, Dr. Rohit. If there are any doubts, participants can ask any doubts to Dr. Rohit. I think there are no more doubts. Thank you so much, Dr. Rohit Reddy, for the wonderful presentation.
Thank you.
Okay, so next we have the panel discussion about a clinical case. So may I invite all the panelists, please tell, are you online? Dr. Asmita? Dr. Asmita?
Yeah, I'm
Are you there?
Yeah, I'm there. I'm there.
Okay. Dr. Tejaswita, are you there?
Yes, sir, I'm there.
Okay. Dr. Bharat?
Yes, sir. I'm there.
Okay. Dr. Prabhat?
Yes, sir, I'm there.
And Dr. Rishabh? Dr. Rishabh?
Yes, sir, I'm there.
Okay, okay, great, great. So I welcome you all for the one panel discussion. I hope that we will all have a good time in discussing this case. So I hope my slides are visible to everyone. I hope my slides are visible.
Yes, sir.
Okay. Okay. So I'll go ahead. So we have a case of 67 years old gentleman who is a non-smoker who presented with mild cough, and his chest X-ray showed a small lesion in left upper lobe. He underwent a CT scan, and CT scan showed lesion in the left apical lobe. Here are the PET scan and CT scan images of the lesion. As you can see, there's a small lesion there, which is the FDG avid on the PET scan. Here is the CT scan report, which reads that intensely FDG avid well-defined lobulated soft tissue nodular lesion in apico-posterior segment of left upper lobe with adjacent pleural tags, features suggestive of primary neoplastic etiology, non-FDG avid subcentimetric prevascular lymph node, likely non-specific reactive nodes, and there is no other metastasis, distant metastasis anywhere in the body of this study. So my question is to Dr. Asmita. Biopsy of this patient showed adenocarcinoma of the lung. What is the next that you're going to do with this patient? Dr. Asmita. Dr. Asmita?
Since the biopsy is suggestive of adenocarcinoma, I would like to have a molecular study in this patient.
Okay, so which molecular study, I mean, which method and which panel would you choose? Will you go for the comprehensive germline panel, genetic panel, or will you have a targeted panel? Or will you have the individual mutation check sequencing?
I would like to have at least the EGFR, ALK, and ROS done in this patient.
Okay. Dr. Prabhat, do you have anything to add or do you concur?
Other than the mutation panel, we would also like to do a baseline workup and a staging workup alongside that to begin.
Dr. Prabhat, the staging workup has already been done. Patient has already undergone a PET scan. It does not show any distal metastasis. What additional staging workup do you need?
MRI brain.
MRI brain. Okay. And is there anything else?
No, just MRI brain.
Okay. Dr. Bharat, do you have anything to add?
Sir, what was the size of the lesion, sir? I just
Size of the lesion is not mentioned in the report. Let's take that it was 3 by 4 centimeter.
Okay. See, sir, this is, it is less than 3 centimeter. So definitely it's one. If there are, if it
4 by 3 centimeter, Dr. Bharat, 4 by 3 centimeter.
Acha, 4 by 3 centimeter. Okay. Still, it comes like early stage 1B. Let's say it is 4 centimeter. So I like to still rule out this PET scan is showing a reactive node. So I think, sir, even the peripheral tumor is also not central. It is let's say it is a peripheral tumor with some PET positive. Achha, sorry, it's PET non-avid lesions. So I think, sir, should be this requires like initial. I think we can complete it as a staging workup is completed. If there is no avid lesions and it is peripheral tumor around 3 or 4 by 3 centimeter, I think we can consider likely for surgery. And here, as per the as the other doctor mentioned, the molecular testing that they will consider, the resectable currently because of the available in resectable cancer, the availability of treating with neoadjuvant therapy, I would also like to get a molecular testing here, preferably EGFR and ALK. ROS, I am doubtful because that was not the protocol as a part in the checkmate 816 where chemo plus nemo was used, where if at all I am going to use the chemo plus immuno only when there is eligible, because the neoadjuvant versus adjuvant chemotherapy not found any any difference in the benefit of survival. So if I'm going to use this as a neoadjuvant part of a neoadjuvant therapy, I would like to get a EGFR ALK status and plus or minus ROS. And then I think.
What is your stand upon MRI brain? Would you like to get it done at this point of time?
Sir, MRI brain usually what recommend NCCN and all recommends is from node positive, that is stage 3 and onwards. So I'm not sure, sir. If
so you will not go ahead with the MRI. You will not ask for an MRI brain.
No, not no.
Okay. Okay. Wonderful. So we have a consensus about molecule. Yeah, doctor. Yeah, speak, please.
Yeah, I would like to add one thing, sir. Since the PET scan is suggestive of non-FTG-avid subcentimetric prevascular lymph nodes only, so I would also like to proceed with the EBUS or EUS.
Okay. Okay. So
And
you will like to
also-
go for the
or
mediastinal
EUS.
staging as well.
If I consider the patient to be operable, then definitely I should be going for a EBUS or EUS to know the exact nature of the subcentimetric, because it has been reported as subcentimetric only. It is not significant if we go per the criteria. But if we go for EUS and EBUS, changes the staging also.
So, but I still have the doubt is here, like non-FTG with that to subcentimetric lesion. I think the sensitivity is quite good enough. We can not consider, like, unless it is like FTG avid lesion where there are two suspicions where we have to go for EBUS in early stage. One is either the tumor is central, then there is a chance of involving either the N1 and N2 disease. Or second, if there is FTG avid lesion with the CT. So there, I think
Dr. Bharat is not in favor of going ahead with a biopsy, while Dr. Prabhat and Dr. Asmita wants to go ahead with the EBUS guided TBNA. Dr. Tejaswita, what is your stand?
Sir, I would also like to go with EBUS.
For the mediastinal staging, right?
Yes, sir.
Okay. Point well taken. So let's go ahead. So what is the diagnostic workup of patient who is suspected to have NSCLC? Dr. Rishabh? I would like to ask you, what are the imaging tests required? What are the workup that you will do in early stage NSCLC patient? What imaging test would you prefer?
So baseline, we would require a CT scan of the patient for diagnosis, CT, and a PET scan staging.
Scan staging. Okay, you would not like to do an MRI?
MRI would be required if the stage is stage 2 or upwards, stage 2, stage 3 and more.
Stage 2, you mean to say if the patient has a tumor more than 4 centimeters, then you would like to go ahead with the MRI, right?
Yes, sir.
Okay, okay, wonderful. So tissue sampling techniques, Dr. Tejaswita, what are the tissue sampling technique that you would like to choose in this particular case?
Sir, probably, sir, EGFR by RT-PCR, I would like to suggest. Hello?
Sorry?
Yes, sir.
Could you repeat? What are the tissue sampling techniques? How would you get the tissue for the biopsy?
Sir, I would like to have an image-guided biopsy. Yes, sir.
Like percutaneous mode, percutaneous through CT guided percutaneous or through bronchoscopy guided?
Sir, bronchoscopy guided.
Bronchoscopy guided. So that is not
Yes,
image guided. Okay.
Yes, sir.
Okay. Okay. So lab tests, Dr. Prabhat, what are the lab tests that you will do? Dr. Prabhat.
Yes, sir. Sir, lab tests on the tissue that we get or the baseline and diagnostic?
Whatever blood test from apart from the biopsy, what other lab tests would you like to run?
Okay, so for the baseline test, we would like to get a complete blood count, LFT, RFT, viral markers, HIV, HBs, AG, HCV. We would also like to get an echo and get a PFT with DLCO for the patient to assess for treatment that we are going to give. Then that is for the baseline workup. Diagnostic we have had in biopsy, and ma'am has discussed we would like to run
We have an image. Right. Right. Dr. Bharat, any other investigation that you would like to add?
Apart from that, what Dr. Prabhat and other doctors told, I think he has covered everything. Even the pre-surgery workup also has covered, like PFT, DLCO, and thing. So
So they have covered the PFT, echo, and the surgical resectability investigation as well. So there's nothing else that you would like to do. Great. So on pre-treatment evaluation, Dr. Smita, would you recommend brain scan? Like we are touching upon this topic again. Would you recommend brain MRI or CT scan at baseline in early NSCLC? Yes or no?
Yes.
Yes. In which group of the patients?
So if the stage is above 1B, I would like to recommend MRI in my patient.
MRI is stage 1B.
Above
Dr.
stage
Rishabh does MRI at stage 2 onwards.
That's what I'm
Are
saying.
there any other?
Above.
Let's get the opinion of other participants. Dr. Bharat, what is your opinion? Stage 1B or stage 2?
I was saying above stage 1B. Beyond stage
Above
1.
stage 1.
Beyond stage
Okay,
1B.
so
That means stage 2 only.
So stage 2 onwards, you will get the MRI done. Dr. Bharat, what is your opinion?
Sir, specific to say, sir, NCN says like 3, like N1 disease are more than 5 centimeter, but the acceptable is even 2 onwards, like above 1B, as the other doctor said, it's acceptable to go ahead and get an MRI. So, but
so you also concur.
Yeah, but
Dr. Tejaswita, what is your opinion?
So
in your practice, in what
onwards.
stage 2 onwards? And Dr. Prabha, do you have any other difference of opinion?
Yes, sir.
Do you have any other difference of opinion, or you also concur that is stage 2 onwards, we tend to get a brain MRI done?
Sir, stage 2 onwards, above stage 1B.
Above stage 1B, stage 2 onwards. Okay, so all the participants, all the panelists are in concurrence that we get brain MRI or CT scan done from stage 2 onward, that is tumor more than 4 centimeter, or according to the 8th UICC 8th stage, tumor 4 centimeter or more, or any nodal involvement. Great. So coming to the role of pathological or mediastinal staging in early lung cancer, we had a difference of opinion here. So Dr. Bharat does not get early lung cancer because he considers that the PET scan is sufficient enough and you can forego for the mediastinal staging. while Dr. Asmita and Dr. Tejaswita thinks that pathological EBUS guided staging has to be done preoperatively. Dr. Prabhat, what is your opinion? Dr. Prabhat. Dr. Prabhat is not there. Dr. Rishabh, what is your opinion?
Sir, during the surgery also.
So I'm asking, do you get it done before surgery or do you get it simultaneously?
Simultaneously.
Simultaneously during surgery. Okay, so is getting tissue sample is a challenge in early lung cancer, tumor relatively small?
Yes.
What is your opinion? What is your experience in your OPD? In your patient, what kind of challenges do you face?
Sir, inadequate.
Are you able to get the biopsy in all patients?
No, sir. Sometimes it is an inadequate sample.
Okay, okay. Great.
And
so what is your approach in such cases? What do you do?
Yes, sir.
What do you do if the size is too small? You are not able to get a biopsy. What is your approach? How do you proceed?
Liquid biopsy.
Liquid biopsy, perfect. So here I'm discussing the NCCN guidelines. So it clearly says that a stage 1A tumor, which includes T1A, B, C, and 0 disease only. So the pulmonary function test has to be done and the bronchoscopy can be done intraoperatively. While if it is stage 1B, which is a peripheral tumor, stage 2A onwards, then the bronchoscopy has to be done preoperatively. So till stage 1A, intraoperative bronchoscopic mediastinal staging can be done. And if stage, not bronchoscopically, intraoperatively mediastinal staging can be done. Stage 1B onward, we have to get a preoperative evaluation of mediastinal nodes done. So in this patient, we did endoscopic ultrasound. There were no enlarged mediastinal nodes seen. Patient is medically fit. He underwent surgery. This is the post-surgical pathology report. We found that the tumor size is 2.9 by 2.5 by 2 centimeter. It was an invasive adenocarcinoma, micropapillary component 25 to 30%. It is moderately differentiated. Visceral pleural invasion was present and no adjacent structure of direct invasion was present. The margins were uninvolved and the regional lymph nodes, the 2 lymph nodes showed metastatic deposits and which did not have any extranodal extension. The pathological stage was given as PT2, PN1, T2N1. So next step, biomarker testing. Dr. Tejaswita, do you check for any molecular biomarker in early lung cancer, either as a specific marker or as a part of multi-gene panel? Dr. Tejaswita.
So no, sir, I don't check for any molecular biomarker at present in practice.
Okay, okay. Dr.
Yes.
Bharat, what is your opinion?
Sir, this is 1B, right? So if you have said like it all depends on the size. You said 4 by 3. If you taken as 4, even the staging also I said based on the 3 and peripheral. So if it is 4, 1B as per if you want to give a benefit like of osimertinib just we discussed in the trial, then I think we should go ahead and get a EGFR. That is one is suggested.
So in outpatient 4 centimeter, you go for molecular biomarker testing. That's what you are saying?
If it is a post if we are not done pre-surgery and the disease N1 disease and T2 pathologically it is T2N1, sorry. So there is
N1 disease we got to know post-operatively only. Pre-operatively we did not know it's N1.
So I think we'll go ahead and get a EGFR testing. So we can offer the patient adjuvant.
You will go for EGFR testing.
Yes.
Okay. So Dr. Asmita, what is your opinion?
I would like to have a molecular biomarker testing in early stage lung cancer also, as I previously said. And in this particular case, I would like to go for at least for an EGFR mutation.
It is for an EGFR, not ALK and ROS mutation?
Definitely, they are preferable, but at least an EGFR mutation is desirable.
So in your practice, such a patient is coming to you, you are ordering only EGFR specific marker or you are ordering a panel of multi-gene testing? What are you ordering in your practice?
Since tissue is always an issue, so if the patient can afford, I will go for a comprehensive profile.
Affordability is not an issue, Dr. Asmita. Let's say that the patient is extremely rich and he just tells you, doctor, whatever you order, I'll get it done. What is your approach now?
Then I will go for an NGS.
You will go for a NGS,
NGS.
like multi-gene panel or specific marker sequencing?
Multi-gene panel, sir.
You will go for a multi-gene panel. Dr. Rishabh, what is your take? Do you check for molecular biomarker or not?
I will check for molecular biomarkers, but I would check mainly for the most common ones like EGFR, ALK, and
Okay. So, Dr. Rishabh, so you check for this molecular biomarker. So, do you do it pre-operatively on the pre-surgery tissue, or you do it post-operatively?
so pre-operative.
Pre-operatively. Dr. Bharat, what is your opinion?
Sir, in this patient, definitely yes, since not mentioned pre-operatively, I'll definitely get EGFR is what at least I should get. The other thing is if the patient recommend, because see, I don't have anything to offer, even if the patient comes any other thing also positive, there is no data to give to the patient. So if you just one question, the answer is EGFR, yes. If the patient has no affordable tissue one-time testing is enough, and in case in future if relapse and all, to have an idea, comprehensive panel is not a bad option. If it is available, I think I won't get that is not a problem. But at present, EGFR is definitely. Then considering to pre-surgery versus post-surgery, if this case, like if as I again mentioned, in this particular scenario, sir, since we are not discussing about a neoadjuvant treatment, and this is a I'm just talking about the checkmate.
Dr. Bharat, this is particular. We are not discussing. Patient is in your clinic. You have to tell him if the neoadjuvant therapy is required. It's your decision.
The patient was initially upfront surgery, then I will get it from the post-surgery tissue itself. No need to go and get it on the pre-surgery tissue.
And of course, if the patient has been operated, then obviously you will get it on the post-surgery tissue. But if the patient that first time comes to you with that imaging feature, as I have previously discussed, so you have a biopsy which is saying that it's adenocarcinoma. So do you get it done on this tissue itself, or you wait for the surgical tissue to be available?
So I think even in biopsy tissue, if what all I'm going to get, I'll get at least EGFR and ALK in the pre-surgery tissue also, if it is available. I'm going to get.
Okay, Dr. Tejaswita, you do not do any molecular biomarker. What is withholding you? Why do you think that molecular biomarker testing in early lung cancer is not important?
Sir, I had actually a confusion because we have already talked about that this point that sir, I thought that ye sab to karwa chuke hain. Now we have to proceed further.
Okay, no. So I was asking whether it is your practice to get the molecular biomarker.
Yes,
so you also think that molecular biomarker testing should be done in even in early lung cancer?
Sir, definitely,
Okay.
sir. EGFR, ROS, and ALK, at least I will go for it.
So which biomarker do you check? Do you consider for PD-L1 testing?
Yes, sir. EGFR,
You go
ROS,
for-
ALK, and PD-L1 we usually do in our OPD also.
In early lung cancer also, you are testing
Yes, sir.
PD-L1 testing?
Yes, sir.
Okay,
Yes,
Dr. Rishabh, Dr. Rishabh, what is your approach?
PD-L1, we don't test in the early lung cancer, mostly in the advanced diseases. For the early one,
So you don't check. So you don't check for PD-L1.
yes, sir. In early ones.
Okay. Okay, Dr. Prabhat, what is your opinion? Do you think that we can make any kind of adjuvant decision based on PD-L1 scoring? I think Dr. Prabhat is not there. So, Dr. Tejaswita, what is
Yes,
your
sir. I am saying that we should check for PD-L1, sir.
You should check for PD-L1. Why so? What kind of decision are you going to make with PD-L1?
In the adjuvant setting, if PD-L1 is more than 50%, because if the
50% in adjuvant, then any recommendation? What are you saying? In adjuvant setting, if PD-L1 comes more than 50%, how will it change your adjuvant therapy?
no, sorry. I think I mixed up. I mixed up two things. Sorry.
Okay. Dr. Bharat, what is your opinion about PD-L1?
Sir, again, this is controversy. See, PD-L1, higher PD-L expression, if you are trying to use post-surgery, there is no data, sir, using immunotherapy as an adjuvant, at least for now. It's all about post-CTRT, durvalumab, where PD-L1 will get, and based on the expression, there is a good response, and with less than 1%, there are poor responders.
So,
in the adjuvant,
so what happened in the atezolizumab adjuvant trial?
if atezolizumab is used,
IM power 010 trial. Yeah. What was data there?
sir, atezolizumab also, irrespective of PD-L1, that's what they have tried.
Okay, okay. So the participants are in concurrence that the PD-L1 should not testing is not very useful. So EGFR, ALK, and ROS testing are the thing that to be used in early lung cancers.
Yes.
So, so Dr. Bharat, in your practice, do you think that how many patients of yours in early lung cancer, which is considering stage 1 to stage 3A, are able to undergo surgery either by upfront or after neoadjuvant therapy? Approximately what percent of patient do you think?
Based on clinical practice, because there is no definite data, but maybe somewhere around up to 70%.
Just tell me the rough idea, rough estimate.
70% of the patient can go for surgery. When they are the resectable cancer, they can go for surgery. The rest of the patients.
So you think only 30% of patients in your practice are actually medically unfit for undergo surgery, and 70% patients are able to undergo surgery?
I think so.
That's
sir.
what you're saying?
Yeah, if the resectable cancer, early stage resectable cancer, I think they will go up to 60 to 70% of the patient will go ahead with get a surgery.
Dr. Asmita, how is the pattern in your OPD? How do you see in this problem? Like we have elderly patients who have lung cancer and they're early stage and they are technically resectable, but still they are not operable or operable. So how many patients eventually end up having surgery? Dr. Asmita, in your OPD, how's the pattern?
So, in our practice, the rate of operability is quite low. As what we go, if we see the institutional data, so the rate of operability is quite low. Whether the lesion is resectable, sometimes
so quite low. Are we talking about like 10, 20%, 30, 40%?
Hardly,
how much are we talking
30 to 40%. It is again an arbitrary figure which I am using. But again, 30 to 40% cases are even when they are resectable, the patient wants to avoid surgery for some or other reason.
That's what we are talking about, Dr. Smita. We are talking about those cases only which are technically resectable, but not operable. We are talking about them only.
I am adding one more thing. Sometimes it is technically resectable, it is medically operable as well, but sometimes the patient should reluctance to the surgical part.
So patient's refusal is also one of the problem that you encounter. Okay, okay. Dr. Prabhat, what do you feel? Dr. Asmita says that it's roughly 30%, approximately 1/3, while Dr. Bharat has a better surgical team and he's saying approximately 60 to 65% patient he's able to get operated. What is your opinion? In your OPD, what kind of pattern do you see?
I would say, sir, about half the patients are manageable.
About half of the patients. Okay,
Yes.
okay. I think in my practice, what I'm seeing is roughly 50%. Roughly 50% of the patients are able to undergo surgery. 50% patients are not able to undergo surgery because of the various reasons like emphysema, poor cardiac reserves, or the patient's reluctance, as Dr. Asmita mentioned. Okay. So I think the second question, what percentage don't want resection, is the reversal of this previous question only, and possible reasons we have discussed. So Dr. Tejaswita.
Yes, sir.
Dr. Tejaswita, so when we are assessing one patient for resectability, what are the various factors that you take in account?
Sir, general condition of the patient.
So that is performance status you are talking about?
Yes, sir. So the ECOG score, it should be not more than 1. Sir, more or less, I have seen in just 1 year of residency, I have seen hardly 4 or 5 patients who have really undergone surgery. So, and most of them were almost about 50 to 60 years of age. And sir, the main thing
I'm asking, what are the factors that you see? What are the factors that you see? Is the age one of the factor that you see?
So the ECOG score is the most important thing. Yes, sir. And sir,
what else do you see?
Sir, the early stage, the stage of the disease.
Stage of the disease. Okay. So how does it manage your decision? Dr. Tejaswita?
Yes, sir.
How does the stage changes your decision? We are already talking about stage 1 to 3A only. All of them are considered to be resectable. How does the stage changes your decision?
So we can go for resection according to NCCN only till, so what I remember is till stage 2A only.
Okay.
Yes, sir.
Dr.
So not
Rishabh,
stage
what
2A,
are the
sorry,
other factor do
it
you?
should be till stage 2B. It should only surgery can be taken into consideration.
If I remember, actually it is the presence of N2 nodes. N2, if the mediastinal nodes are present,
Yes,
even
sir.
in that, there are certain subset of the patients in which there is a single stage N2 disease and the
Okay,
lesion
sir.
is otherwise resectable, then we can consider. But if the N2 disease is bulky, then it becomes inoperable. So what are the other factors, even apart from the stage, what are the other factors that should be considered? Dr. Rishabh, what are the other things that you are looking at?
So we have to look at the cardiopulmonary reserve of the patient.
Right.
Other morbidities.
What are you looking at? Comorbidities, the cardiopulmonary reserve. How do you assess cardiopulmonary reserve?
So we can look at FEV1, the post-surgical expected FEV1, the LCO level use of the patient, basically PFTs.
You see the PFT, you see the 2D echo, and then you decide based on that. Perfect. So we'll talk about the role of radiotherapy in early lung cancer. Dr. Asmita, what do you think is the role of PORT in early stage resected NSCLC? Are you frequently using it in your patients?
See, in early stage resected non-small cell lung cancers, the role of PORT is only if the margins are positive.
So apart from that, you are not using it for any other indication?
No.
Okay. Dr. Prabhat, what are you doing with your patients post-operatively? When are you referring them for radiotherapy to radiation
Positive
oncology
margins.
colleagues?
Positive margins.
That's all? Okay. Dr.
Or
Prabhat.
else, yes, positive margins, and if the patient cannot undergo surgery.
Patient cannot. No, I'm not undergo surgery. We are talking about post-operative RT. Patient
Only
has undergone
positive
surgery.
margins.
We are not talking about definitive CCRT. We're talking about post-operative RT. So positive margin. Dr. Bharat, do you have anything to add?
No, sir. Actually, that is right. Actually, only positive margin we refer to RT. Adding RT to R0 resection actually found to decrease the survival, increases the complication. So better to avoid it. Some people have tried like bulky N2 disease when got initially upfront operated. Tried RT, found to have significantly reduced the local recurrence, but in the long run, the survival there was no much difference.
Survival was not different. You are talking about Anita trial, I guess.
Yeah.
You're talking about lung art trial and Anita trial.
Anita trial and lung art. Yes.
Yeah, right. Dr. Rishabh.
Yes, sir.
What is your practice for adjuvant radiotherapy?
Sir, only positive margins.
Only positive margins. So I think we have fair consensus within the panelists that we are undergoing post-operative, we are taking patients for post-operative radiotherapy in case of positive margins. I usually sometimes, if there is somehow the N2 disease is there and it has been resected somehow, although there are very fraction of cases are there like that, then also post-operative RT can be considered. But then of course we have to look at the comorbidity profile and performance status post-operative of the patient. So sometimes it has to be a multidisciplinary tumor board decision, and case-to-case basis in cases of bulky N2 disease, the post-operative radiotherapy can be considered selectively. So when we talk about inoperable cancer, we have already talked about that there are some patients who are technically resectable, but then they are medically inoperable. So the role of SBRT has come up a big time. So Dr. Tejaswita, what do you feel about the role of SBRT in early NSCLC? What kind of patient, what are the fraction of patients that you choose for SBRT?
So very less percentage of patients, practically speaking. I think hardly.
No, I mean, what are the criteria for selecting a patient? Like what kind of patients are you referring for SBRT rather than a surgery?
So basically, who have a quite higher ECOG score.
High ECOG score, as you mean
Yes,
score
maybe
5, score 4?
greater than 1.
Greater than 1. So patient has ECOG performance status 2, we are referring for SBRT.
Yes, sir.
So if the patient has a lesion 4 centimeter in left upper lobe and has N2 disease, so you are referring that patient for SBRT?
No, sir. This patient I won't refer for SBRT. So there should
Okay,
be,
why so?
Sir,
Suppose this patient has performance status of 3, patient has N2 disease, bronchoscopically you have proven, and patient has a peripheral 4 centimeter lesion in left upper lobe. So do you think this patient is a candidate for SBRT? Dr. Rishabh?
No, sir. SBRT is mostly effective in the early stage NSCLC only. Advanced stages.
No, I'm not talking about the advanced stage. It's a peripheral lesion with one N2 node. So what kind of patient? How do you select the patient who are ideal candidate for receiving SBRT?
Sir, mostly node negative patients we will consider for SBRT.
So node negative
Okay.
and single lesion maybe. That kind of
Yes, of
patients we
course.
can. Yes,
Because
sir.
of course the SBRT is stereotactic radiotherapy. So the
Yes, sir.
radiotherapy beams are highly localized. If you have multifocal disease nodes as well as the peripheral lesion, how are you going to target the entire lesion? Of
Yes,
course,
sir.
Dr. Asmita, any other patient characteristic you take into account? Dr. Asmita.
Am I audible, sir? Am I audible?
Yeah.
So,
Yeah, you are audible.
so SBRT is now the standard of care in patients who are having an early stage disease and who are medically inoperable. And
Okay.
ideally, when we are considering SBRT, then the treatment volume should not be very high because it will be adding the toxicities to the patient. The chronic toxicities will be there. Late effects of radiation will also be there. So the tumor size should be small, and nodes, even if they are there.
Small, what do you mean when you say small? What do you mean? It's like 1 centimeter?
No. It has to be less than 4 centimeter.
So
Less
4
than 4.
centimeter, you
Less
think
than
that
4.
the patient
Less
is
than
fit
4.
for SBRT?
Yeah.
And what about the nodal status?
Even if the nodes are positive, and I consider that the tumor is central in location and the nodes are positive, and if they can be encompassed in the same cross tumor volume, then definitely we can consider for SBRT.
Okay, so you are taking the central location, central tumors with the N2 nodes also in SBRT.
No, not N2, sir, not mediastinal.
Okay.
No.
Okay. So for SBRT, usually we are taking the patients who are medically inoperable, who are not fit for radical surgery or even for the concurrent chemoradiotherapy. They are too sick. So those are the patients who have very small lesion up to 4 to 5 centimeter. We can take institutional practices vary. And usually peripheral lesions are more suitable for SBRT who do not have nodal involvement.
I agree with you. The peripheral lesions are more suitable. But even if I consider the patient is having an advanced status and it is a small nodes, sub-centimetric or centimetric nodes only, and it can be encompassed in the same field along with the primary tumor.
I agree. It's a case-to-case, basically multidisciplinary tumor board decision. Case-to-case basis, it can be done in a selected number of patients. But grossly speaking, the patients are not very fit for the radical surgery or CCRT, and peripheral lesion is small single lesions. These are the patients who are fit for SBRT. So I'll ask the next question to Dr. Prabhat. Dr. Prabhat, what is the role of neoadjuvant therapy in early NSCLC?
Sir, can I ask a question, sir?
Sorry?
Sir, can I ask a question? Sir,
Yeah,
does
sure.
SBRT and consideration of performance score, should we consider performance score also for SBRT or not? Because on one side we are saying the lesions, the disease volume should be less, and then other side we are saying that the patient is not medically fit to undergo surgery and all.
Yeah, patient can have severe emphysema, but the disease burden might be low.
Okay, sir.
We are talking about patients who have low disease burden, but they're medically inoperable due to other comorbidities.
Right, sir. Okay, sir.
like we talked about initially, that only 50% of the patients are able to undergo surgery, rest 50% are not able to go because of the other comorbid conditions.
Okay, sir. Okay.
Okay, so disease burden is not the only thing which is causing poor PS. Usually because these patients are heavy smokers sometimes, so that is why the emphysema is there, or their poor cardiac results might be there, ejection fraction might be low. In such cases, we prefer SPRT.
Okay, sir. Right, sir.
Okay, so back to you, Dr. Prabhat. What do you think is the role of neoadjuvant therapy?
No, sir, not in early.
So you're not using neoadjuvant therapy at all?
In early stage,
Preferably, any particular subset of the patient in which neoadjuvant therapy?
EGFR positive अगर है, if it's
so EGFR positive patient, then what do?
We use osimertinib, but I'm not
in
sure
neoadjuvant setting.
No, that is what, not in neoadjuvant. I'm not in neoadjuvant. We are not using, sir.
So you're not using. No, I'm not only talking about osimertinib. I'm talking about any neoadjuvant therapy. Are you using or are you not using any neoadjuvant therapy?
No, sir.
No, you're not using. Dr. Bharat,
Sir,
what is your take?
there is a role of neoadjuvant therapy at present, at least not in the era of chemotherapy, where nivolumab and chemotherapy regimen was been tried in checkmate 816. There is found to have definite higher PATCR rate also, and also disease event-free survival is also higher.
Definitely, absolutely. What else apart from that?
Sir, apart from nivolumab, there is a trial that is still may not be having mature or release data where durvalumab plus chemotherapy, however, followed by continuation of durvalumab in the adjuvant
So
setting.
we are not talking about trial. We are talking about what is your practice. Are you using neoadjuvant therapy for any other indication?
Achha. Sir, apart from this, even surgical N2 disease like peripheral surgically resectable cases, especially N2 disease, there is a role of using neoadjuvant chemotherapy followed by surgery, like preoperative chemotherapy followed by surgery. We can go ahead. Otherwise, CTRT when there is not considered like bulky N2 disease. So there are two options when there is a doubtful N2 disease whether to operate or not. There we can go ahead with if there is a delay, RT dates are difficult to get a definitive CTRT is a problem, and the patient is resectable and operable, then using neoadjuvant chemo is another area where we use.
Absolutely. Dr. Tejaswita, any other tumor, the primary tumor consideration which can guide you towards neoadjuvant therapy?
SVC.
So SVC
any primary tumor consideration which guides you towards neoadjuvant therapy?
So at our setup, so we don't advise for it in early NSCLC.
So you're not using neoadjuvant therapy in any cases?
No, sir,
Okay.
not seen yet, sir.
So,
yes,
Dr. Bharat, what about the Pankos tumors?
That's what
P4 Pankos tumors.
I just mentioned SVC, it is a Pankos tumor where we have to use neoadjuvant.
Exactly. So as I considered neoadjuvant therapy in Pankos tumors, in N2 diseases, and in now that we have checkmate 816 trial, so neoadjuvant nivolumab has shown good benefit in in tumor more than 4 centimeter in size. So in this patient, it is a stage 2 adenocarcinoma. We got a molecular panel report done, which is suggestive of EGFR mutation in L858R. Mutation was present. So Dr. Asmita, next question to you. What is the role of adjuvant chemotherapy in this patient?
We can give adjuvant chemotherapy, but considering the results of ADORA trial and with the EGFR mutation positive in this patient, I would like to go for adjuvant osimertinib without chemo.
So you will not give adjuvant chemotherapy?
If we see the results of adjuvant chemotherapy also, since it is a stage 2 adenocarcinoma, the overall survival benefit which I will get in the long run is small. The chemotherapy shows only a 5.4% overall survival, a 5-year-old survival.
Bharat, what is your stance?
I think I'll get that benefit also. Adding, I'll give 4 cycles adjuvant chemo, followed by definitely give a osimertinib, but I'll give chemotherapy in this patient. A node positive disease, and it's not definitely this thing.
So what do you think in EGFR positive disease, there is doubtful benefit of adjuvant chemotherapy? That's what you are saying?
No, there is benefit in these patients adding chemotherapy, and but
So
what
was there in? Okay, so Dr. Rishabh, what is your approach? What do you think?
So there is the role of adding adjuvant chemotherapy in the patients. Along with
So you
osimertinib.
will give adjuvant chemotherapy.
Yes, sir.
And what about adjuvant osimertinib?
From stage 2B onwards, we will give adjuvant osimertinib also.
Sir, if I'm not confused, I mentioned chemo plus osimertinib, not only chemotherapy. Chemo plus osimertinib that I will give. Even though trial says with or without chemotherapy, using adjuvant osimertinib did not find much significant difference. But considering the long-term practice of using adjuvant chemo, and there is some definite significant benefit.
Dr. Smita, in ADAURA trial, the osimertinib was given after patient received 4 cycles of adjuvant chemotherapy. So adjuvant chemotherapy is to be given.
Yes.
And we add osimertinib after chemotherapy. Osimertinib does not substitute for adjuvant chemotherapy.
Okay.
Dr. Smita.
Yeah, I stay corrected.
Okay. Thank you. So, so what is the benefit of adjuvant chemotherapy? What are the drug regime that you will use, Dr. Tejaswita?
Sir, for NSCLC, we can go for pemetrexate, carboplatin.
How many cycles will you give? How many number of cycle you give in these patients?
So 4 cycles.
You are going for 4 cycles. Okay. Dr. Prabhat,
yes.
What is your practice? How many cycle you give in adjuvant setting?
4 cycles, sir.
4 cycle. Dr. Bharat, do you agree?
4 cycles.
Okay. Dr. Smita.
4 cycles.
Okay. And Dr. Rishabh, do you agree or do you have any other opinion?
I agree, sir. 4 cycles we have to do.
Okay. So adjuvant chemotherapy for NSCLC. So we have a list, a meta-analysis in which there were 5 randomized trials were taken, and the pooled individual patient data was presented in which maximum patient were stage 1, 35% patient were stage 2. And if you see that 5-year OS benefit was there in 5.4%, 5-year OS benefit was there. So if you divide it stage by stage, if you see, so the maximum benefit was seen in the stage 3, then stage 2, and followed by stage 1B. Stage 1B, there was small magnitude of benefit. So, but what we take it as stage 1B onward, we tend to give adjuvant chemotherapy. Now we have data from ADAURA trial, which is role of adjuvant osimertinib. So in this trial, you see that AJCC staging at the diagnosis, 32% patient were stage 1B, 34 patients were stage 2, and 35 patients were stage 3A in all the arms. So 1/3 patients were there from the each stage. And if you see that the 68% patients were female, as we already know that EGFR mutated lung cancer is more common in the females. And out of that, if you see that adjuvant chemotherapy received, 60% of the patient had received adjuvant chemotherapy as well, and the 40% patient did not receive any adjuvant chemotherapy. So osimertinib can be used in both ways. So the thing is, sometimes if the patient is stage 1B, we tend to avoid adjuvant chemotherapy. Sometimes we choose not to go with adjuvant chemotherapy and directly go for adjuvant osimertinib. But otherwise, if the patient is fit, and in this particular case, the stage was stage 2. So I think we would like to go ahead with the adjuvant chemotherapy followed by osimertinib. So ADAURA trial, if we see that the stage 2, stage 3A, the median DFS was not reached in the osimertinib, while it was 19.6 months in the placebo arm with a hazard ratio of 0.17, which is very, very significant. And if we talk about stage 1B, then we see that the hazard ratio was 0.20, which is also very, very, very significant. So absolutely osimertinib has to be given. So opinion about ADAURA data in context of the previous adjuvant trial, we have already talked about in the Radiant trial, the Adora trial, and the CTONG trial, we see on other trial had shown only the DFS benefit, while Adora trial has shown OS benefit also. Adora, the AstraZeneca have released a press release in which they are saying that the OS benefit has also been observed, which is the first time that some adjuvant targeted therapy has shown OS benefit. All of the previous trial had shown only benefit of DFS, although the full paper is not published yet and we do not know what is the quantum of benefit. And the recurrence pattern in the patients, we see the local or metastatic recurrences. 11% of the patient in the osimertinib arm had DFS event, while 46% of the patient had DFS event in the placebo arm. In the osimertinib arm, the majority were local or regional recurrence, and while 38% patients had metastatic recurrence. And in the placebo arm, 61% of the patient had metastatic recurrence. So what we can see here is that osimertinib prevents some metastatic recurrences and CNS recurrences, the 10% in the placebo arm and only 1% in the osimertinib arm. So is Adora practice changing? What is your thought about it, Dr. Tejaswita? Taking all this data into consideration, while Adora trial has shown DFS benefit as well as OS benefit, and toxicity profile of osimertinib is also very much it's good. It's what? So, do you think Adora is a practice-changing trial?
Yes, sir. Definitely, sir. It is
Okay.
practice
So,
changing. Yes, sir.
Dr. Rishabh, what is your opinion about Adora?
I also find that Adora is a practice-changing trial, sir.
So, how has it changed your practice?
So now we should add osimertinib to the regimen, like the treatment to the patients.
Okay, Dr. Smitha, do you concur or do you have any other different opinion?
I perfectly agree. It is a practice-changing trial, and because it is giving a very clinically meaningful disease-free survival benefit and overall survival as well.
Okay. Dr. Bharat, do you agree?
I agree with the practice changing thing, but I'll just little modify if at present in my clinical practice, because the population that included started from 1B to 3A, and the 5-year survival already in population 1A is more than 70%, 75% if I'm not wrong. And the survival decreases with the stage, like 2 and 3 onwards, it comes to less than 20-30% in stage 3. So most of them will recur in stage 2 and stage higher diseases. So in stage 1B, I think even instead of using osimertinib, there are very less chance the people who get recurrence are. So instead of using for all stage 1B disease.
So you will not use osimertinib in stage 1B patient?
No, I still want to see that OS data. What is OS data and the subgroup analysis? Whether really there is a OS difference in even stage 1B group or it is just for subgroup of population. Even without the data, I can expect like it is the overall survival. If there is a benefit, then definitely that will be in the stage 3, and some part of it is stage 2. I don't think there is any overall there will be any overall survival difference in stage 1B. This is what my guess is.
Okay, so we don't have a OS data, published OS data yet for the subgroup analysis.
Yeah, if
so you are holding your
there
cards.
is overall survival benefit even in stage 1B, then I'll change my decision. But for now,
so for the time being, you're holding your card for stage 1B, and you think that right now, as of today, on 24th of March, if some patient comes to you with EGFR mutated stage 1B resected tumors, so you will not give osimertinib.
I think most of them will do without any recurrence. My guess, like 5-year survival is more than 17. Lung cancer, it's okay, quite good. Many of them may not recur osimertinib.
Okay, I got your point, Dr. Prabhat. What do you think? Stage 1B patient in today's date, as of the condition now, will you give or will you not give osimertinib?
It's controversial, sir. I mean, if
see, it's you
there
are
are
the
high risk
treating
features,
physician, you are an
then
OPD,
as per the
patient comes to
guideline,
you.
we have to give.
See, patient has complete faith on you. Patient is saying, Dr. Saab, I do not have any money issue. I don't have any problem. Whatever you say, I will get it done. So now it's your decision. So what will you tell the patient? Will you advise to take it or not?
I will advise to take it.
You will advise. So you are also, initially you were not giving any therapy. Now you are giving Adora. So in your perception, do you think Adora is a practice changing? But
yes.
Has it changed your practice?
Yes.
Okay. So I think most of the panelists are in concurrence that the Adora is a practice changing trial and it has led to wonderful results by adjuvant osimertinib, although of course the OS data is not published yet and we do not have subgroup analysis in which stage it has the meaningful OS benefit. So if we talk about the NCCN guidelines, although it is a slightly older slide of 2021, if we see that in stage 1A, if the margins are positive, then we go ahead with re-resection, which is practically, of course, not possible, and we go ahead with the radiotherapy. In stage 1B onwards, we go with chemotherapy for the high-risk patient, and we add osimertinib according even in stage 1B. And stage 2A onward, we go with chemotherapy. And stage 2B and 3A, of course, chemotherapy and osimertinib. Thank you. So if there is any question, any discussion, any point raised, then panelists are most welcome.
Thank you for involving.
Hello, I have a small query.
Yeah.
Yeah, is adjuvant osimertinib approved in India for adjuvant use? Is osimertinib approved for adjuvant use in India, sir?
DGCI approval?
Yeah.
Yeah. So far, actually, it is not approved. The status remains not approved because usually DGCI takes some time for the overall survival data to be mature before it gives approval for use in India. But we are giving it, and there is absolutely no problem. You can justify it by the NCCN guidelines and the result of ADAURA trial.
Okay. And one more question. Since the study ADAURA is for osimertinib only, and in our Indian conditions, the affordability of the patient is quite poor. So can we use erlotinib or some other geftinib first generation in place of osimertinib?
Definitely. I feel that definitely you can use because geftinib and erlotinib previously the trials have been there, as we have already discussed in this presentation, and the previous speakers have also mentioned about the Radiant trial and other trial in which the erlotinib and geftinib have been tried in the adjuvant setting, and they have shown some DFS, meaningful DFS benefit, but unfortunately the OS benefit was not shown. And given that these drugs are toxic, erlotinib and geftinib have their fair share of side effects. So that is why it was not routine practice. But I think that it is more of a class effect. And this, even the first generation erlotinib and geftinib would be beneficial to prevent recurrences. So I think, in my opinion, you can give erlotinib and geftinib if the patient is not affording for osimertinib. However, you have to keep in mind that the magnitude of benefit might be small, and you have to monitor for the toxicity. And if the toxicity greatly or higher occurs, then you should stop it. That's what my opinion is.
Thank you, sir. Thank you. And thank you for giving me this opportunity to join you.
Okay, the pleasure. So are there any other questions? So if the question is, there are no more questions, then I think we can conclude this session. So it was a wonderful opportunity to have a wonderful discussion on this. So hand over to the organizer.
Thank you, sir. Thank you, everyone, for joining, and thank you for the wonderful discussion.
Thank you, Kapil, sir.